Thank you to everybody for joining us this afternoon. We very much appreciate your attendance and participation today for the second meeting of this care coordination work group, so we appreciate it. Today is a little bit different. That is, it is an opportunity for learning, for some discussion, for engagement, and really for some idea generation. And quite frankly, we probably all don't get that much of an opportunity to do that on a day-to-day basis. The team here has put together what I think is a very thoughtful agenda, and I guess I'd comment thoughtful in two ways. First of all, we've had an opportunity to invite some guests from both inside and outside of the state of Maryland to share their experiences, their successes, and their challenges, and I think that's going to be quite helpful. But thoughtful as well that as we bring examples, we have had a discussion internally that we understand that these are just examples, and they are some examples among many. And the challenge for us today is to really identify what it is about those activities, those actions, that have really led to success. I think I talked about the secret sauce. What is in that secret sauce? So today we want to focus not just on the what that some of these folks with examples and experience in the field have experienced, but how they did it. Because at the end of the day, what we hope to do is to understand what are those elements of success that we could bring to bear here in the state of Maryland. So our agenda today, as you can see, we are going to start with a look at the data. And in a moment, we'll turn it over to Donna Kinzer from the Health Services Cost Review Commission to do that. We'll then have an opportunity to have a dialogue with some folks from the field. We're very grateful to all of our guests for being here today. But we are going to spend the bulk of our time under Jack Meyer's leadership and tutelage as we really begin to synthesize some of our thinking and some of the questions that we hope to begin to address today. What are the successful components of care coordination? How might approaches be spread here in Maryland? What would be needed to make some of the approaches we're going to hear about today work or work better here in the state of Maryland? And what barriers would we need to remove? My last thought is that we are hopeful for a thorough discussion today and that for this work group, a discussion that is ultimately going to be helpful to the field. As a staff team, we have also said that we need to start where Maryland's hospitals are, and there has been a lot of work already done, and we are moving speedily down that path. But we also don't want to miss an opportunity to say where are the places where we can come together to leverage our collective strength to move things even faster and even more successfully. So with that, let me turn it please to Dr. Laura Scott for.
So I don't really have anything to add other than to say thank you, and you know, we hope to accomplish a fair amount in a short period of time, and hope after this meeting and hearing about what's happening in the state of Maryland and outside of the state of Maryland to really start defining what is needed, or at least what the floor is for care coordination in Maryland, both for acute transitions and then longer term. So, you know, we thank you all, not only for the speakers here today, but certainly for the members of the group and the public comments that we'll hear from later today. So thank you.
Thank you. I'm really looking forward to hearing the presentations from all of the speakers today. And I just wanted to start off the process by talking about some of the data that we've been looking at and really the importance of targeting when we begin down the road of care coordination. And part of the reason why we were at the HSCRC so anxious to have a work group focusing on this to think about this together. Care coordination is certainly central to the goals of the all-payer model of making sure that we're achieving what we need to do in terms of savings by taking opportunities to improve care. And in my point of view, and certainly others, the accessible care coordination strategy has to take advantage of data to drive that strategy, to make sure that we're focusing the efforts on people who will benefit from care coordination, understand what the characteristics of the people who will benefit and their needs, and to create targeted interventions for those individuals. And just to begin to walk down the road of looking at who those individuals are from the hospital perspective, because we are focused at the HSCRC on hospital data, and we do not yet have all provider data in our hands, although it's in process. We have started to look at the hospital data. We began doing this with Dr. Herrera when we were working last year, focusing on the population characteristics. And there are more sophisticated ways to do targeting, and we're very we think it's very important to get more sophisticated in targeting. But with that said, we took all of the HSCRC discharge data, inpatient and outpatient. We took just the inpatient and emergency room data, so we excluded things like outpatient cancer care, et cetera, which is something that wouldn't be something that you would be trying to do with care coordination or case management. And we grouped all of the encounters together for all of the patients across the state using the CRISP ID, so that we now have patient-centered records of utilization and cost in the data. We also added clinical classification categories using the ARC classification to enable us to look at conditions at a rolled-up level so that we wouldn't be wallowing too much in the detail. So one of the first questions that we start to ask is, well, how are we going to segment a population of utilizers to pick patients for potential care management intervention? And certainly people talk about picking the highest cost patients. So, you know, one approach is to say, oh, let's pick the 10% of the highest, the patients who represent the 10% of the highest cost, 10% of charges. So let's pick all of the high cost patients. And then another approach is looking at high utilizers. So we're going to walk through an illustration of the impact of those types of decisions and how they impact the number of people you might be trying to manage, as well as the cost of the intervention. Because I think if you've heard a lot of the presentations about the cost of intervention, a lot of times the cost of intervention can outweigh the savings. So we're going to kind of look through and walk through that kind of a thinking process. So on one hand, we're saying, well, let's pick individuals who had more than 3 inpatient hospital visits. And that turns out to be about 3% of the patients, about 31% of the charges that are included in the data set. The average patient had $74,000 of applicable charges, 4.3 inpatient visits per patient. And so that's what happens when you take that high utilization segment. So that's about 41,000 people. Now, if you go to the high cost segment, then, and we're looking at the 10% of annual charges, that gives us about 136,000 patients in the population group. Now, you all do have a copy of these slides. I know these numbers are small up on the screen. So we have a much larger set. And when we start to drill down into the high cost patients, we see that 44% of those patients are actually, or 44% of the charges are actually the patients with 3 or more inpatient visits. But then we get down into that high-cost population, and we find that 43% of the patients also had only one visit. So you don't necessarily want to be chasing them with a care management intervention if they're only going to end up with one hospital visit. And so that might end up being patients like NICU babies, et cetera, and so forth, or other very expensive interventions like transplants, for example. So continuing on down the storyline here, then we are looking to see, well, who are these patients? And what we find out is that 66% of the patients and 65% of the charges are Medicare or are dual eligible, which is certainly part of the reason that we're focused really heavily on those populations in this work group. Then we can begin to look at the geographic distribution of the patients, and this is the 40,000 utilizers, not just the Medicare utilizers. And I know that you can't read these high utilizer numbers here on the right-hand side, but we just calculated the number of high utilizers per 100,000 population in each county. And I had been looking at some raw figures, so I was expecting Baltimore City to pop up to the top, but it actually doesn't. It actually has a lower number of utilizers, but that is partly because of the age distribution of the population, for one reason. So, we could actually begin to just focus this on the Medicare population, and I know that the high utilizers per 100,000 would change if we just use the Medicare population as a denominator and the Medicare users in the numerator. But I guess what I learned from this is that there's a pretty good distribution of high utilizers in every county of the state. There's a good number in every county. Then I'm an accountant, so I have to get into the cost of intervention and why I'm really concerned and pressing people to collaborate together in terms of thinking about and investing in analytics and intervention. So as we take these two options in our example, and on one hand we have about 40,000 patients, on the other hand we have about 136,000 high-cost patients. And if we just move down and include the Medicare patients, that drops us down to 27,000 for the utilization approach and 79,000 for the high-cost approach. If it costs us $3,500 per patient for an intervention, and there are ranges, but that's within a range, then if we are chasing 27,000 patients, that's $95 million. On the other end of the scale, it's $277 million. If we assume and on the left-hand side we have $1.9 billion of charges, on the other side we have $3.8 billion. If we assume that we're getting the same savings level from each group of 15% from each side of the equation, then we get $280 to $570 million of gross savings. But hospitals know that's not real cost savings. There's fixed costs and variable costs. So if we cut that in half to represent the variable cost savings, then we get down to $140 million versus $285 million. If we then subtract the investment and intervention costs on the first side where we really targeted a little bit more, we end up with a net savings of $45 million. On the other side of the equation, we end up with a savings of $8 million. So really, point is that targeting really matters, and it'll be something of in my lesson number 1, lesson number 2, and lesson number 3. Just to kind of set the stage a little bit more in terms of the patient characteristics of the, and so we're going to switch and talk just about the Medicare population and the and moving forward to talk about some of the patient characteristics. Even when you start getting underneath the populations that we have, you'll really want to drive much deeper into the data as you think about and plan your intervention. So we did a simple split of looking at some of the over and under 65, so we have Medicare, and we have over and under 65 Medicare, and we've drilled down in here to look at some of the characteristics of those populations, and we've also split out the dual eligible. And what you will start to see is that the older, whoops, keep hitting the wrong button. The older patients, older Medicare patients, use the emergency room much less frequently than the younger disabled patients. The younger disabled patients, a lot more HIV as one of the conditions. And even when we begin to look at behavioral health conditions, we'll see quite a difference between the over and under 65 populations, which with a much more significant behavioral health conditions in the under 65 population. So again, starting to drive toward understanding our utilizers and the interventions that might be needed. The next 2 slides, I'm just going to breeze by them, and I'm not really going to make you try to dive into this incredibly fine print, but really just to show you that you can continue to drill down into this patient-centered data and begin to think about what conditions are prevalent in the population, that you would want to be targeting from a medical standpoint. Now, that doesn't even begin to get into the social service components, but from the medical components, what are the patient's chronic conditions, and what are the conditions that are causing them to come to the hospital? And then if you look at these, you will see a difference, and you look at a larger, more detailed version on your computer screen, you will see a difference in the over and under 65 population. So I think when you get to this, when you get through the data collection, all of the best practices say that you need to take it to a next level and do a health risk assessment to where we're looking at how patients are doing in their home environment and the support system to do more targeting. Again, because we don't want to spend $3,500 on somebody who doesn't really need care management intervention, and be able to find those patients who might benefit from effective primary care more than care management, or separating out patients in assisted living and nursing homes and doing a whole different set of interventions for those individuals than we would for than assigning a general case manager. So those are just some very high-level beginnings, if you will, of diving into our data here in Maryland. And the kind of the takeaways are that case management and disease management activities are expensive, and the benefits of targeting interventions are well known. They've been well known for actually decades, and so we're going to relearn them now, but we want to learn them quickly so that we don't, so that we actually spend a good bit of effort on targeting our intervention. There's numerous parties involved in our interventions, and the data acquisition and the analytics process is expensive, is complex, and it could really benefit from scale instead of doing it one hospital at a time. So the things that I really would be hoping that we can move forward from here is to focus on statewide infrastructure to help support the targeting and the data analytics and potentially community case management types of software that can go across the many provider organizations that are involved. And that we can continue to evaluate the best practices for these high-need patients and how to best target the interventions that are going to be applied and how those can be scaled. So those are some of the things that are really jumping out of the data as we began to look at it from the HSCRC, and we're really looking forward to hearing how some of the presenters have tackled these issues.
Thank you, Donna. Can we open it up to questions, please, for Donna? Yes, Mark.
Mark Television Month. This is a nice way of describing a population of people. But do you have any sense of how many of that 27,000 would have been predicted from those same people in the previous year or taking that group in the subsequent year? Because some subset of those are going to be single catastrophic nature events that come up in that year who you couldn't have really probably focused these kinds of activities.
Well, I think that we're very anxious to see predictive modeling techniques be applied to data and to bring the sophistication of the process along higher and higher. Without going into more depth, no, I don't have the answer to that question about how many of those particular persons would be predicted to be high utilizers in the next year.
Can I just say to them, Mark, you just made a really important point. Could you just talk a little bit more about that and the separation between describing populations and predicting populations, just to make certain everybody's on the same page?
So when we talk analytics, just descriptive analytics describe a population, something that's already happened, right? And predictive analytics is when you start taking information that may or may not be relevant, developing algorithms and deciding based on this set of predictors, maybe it's previous utilization, maybe it's socioeconomic factors, maybe it's numbers and conditions, who are the likely people to be needing these services, either high utilizers or high cost in the subsequent year. Because it's not going to be 100% of those 27,000. Many of those 27,000 probably died in that year. So, so I think one of the goals that we try to get is there an even smaller group of people, maybe 10% of that 27,000, who show up year after year, and you could really start to make inroads by focusing even more tightly.
Thank you for the explanation.
If I could ask, excuse me, Laura, this is a webinar format. That means some people are listening in remotely. So in these cases, like the Lord's, but either we will introduce you or give your full name so they know who's speaking. Thank you. Go ahead.
Lori Doyle. I'm curious about how the conditions themselves are identified. Is it the presenting problem that someone came in to the hospital with? So hypertension is the condition and is listed there as hypertension. What if somebody comes in with hypertension but also has depression? They're not coming to the hospital for depression ostensibly, but they have it. Is that captured in this data, or is it how does it
flag every condition, and so so it's not just the principal condition, but all of the conditions are flagged. And certainly one of the ways that you can look at whether somebody's likely to be a utilizer again is if they have CHF, COPD, and diabetes, they probably are still going to have it next year and the year thereafter. So there are certain things that we would do to, if we were using this and not a more sophisticated predictive modeling tool, we would take this down to additional levels to look at what conditions the patients have and whether they're chronic, recurrent types of conditions, which would lead us to believe that they would be more likely to utilize services again. And you will see when you start looking through this list that there's an awful lot of chronic conditions in the list for those patients.
Yes, Dr. Hack?
No, you finish this part.
Howard Hack. Because of your comment about the fact that this is a narrow slice, speaking of people who are in the HSC database that have been hospitalized for one reason or another, I think it's very relevant to what Dr. Kelman said also, and that people, that represents maybe in this study 140,000 or so, 150,000 people out of 6 or 7 million in the state. This population, as you said, people who will be moving out because either they get healthy or they die. But there's a large reservoir of people on the ambulatory side who are not yet counted. And those are interventions that are targeted toward the very high utilizers are expensive and late in the game. They're largely people who have advanced disease. Being able to focus and broadly include the ambulatory side as much as possible, which I know is everyone's hope, I think ultimately leads to being able to have interventions that are earlier and less expensive and spread over a broader population. And in the end, really the only cure is for the healthier population, not to try and put a Band-Aid on those who are the sickest and closest to death.
I couldn't agree more. There's a much larger N of population below this small group of high users, and the focus of really taking care of those individuals in the primary care setting, in the community setting, is really critical. It's not a case management activity, but it's really more of an intervention that needs to happen in the office-based settings. So I think that's very, very critical, and you know, that needs to have the same level of attention as case management in terms of developing intervention.
And even there, I think the lines of where it's case management or care management occurs as a consequence of integrated into primary care or ambulatory care now, not maybe to the same extent, but to a growing extent as it is in the hospital. So being able to blur those lines and integrate that, I guess, is really the fabulous thing.
And can I make just one comment before I see somebody with their hand up? Jim, hi, how are you? Let me just explain how we're going to attempt to do this, if it's all right, especially for so many of you who have come to listen to the discussion. We're going to take questions from the work group first, if we could. If we can, we'd like to hold questions from the audience until after the presentation section when we get into the facilitated discussion, and then we'll let Jack duke it out and make certain. We promised to try to save you enough time. I'm so sorry. Laura, thank you, John.
Yeah, thanks. It's John Chenatek from Care First. Donna, I was wondering if you were surprised by the pattern that you've seen here, namely that the older beneficiaries, let's say, had less emergency room visits and less behavioral health comorbidities. It's a bias. I'm just thinking with increasing age, we tend to have more comorbidities, and I'm thinking there probably are more mood disorders and cognitive issues that come in. So I'm just wondering, was this surprising to you? And do you think this is, I'm wondering if also this is heading us and saying, okay, if we're going to target, then target the younger.
Well, I don't. When you actually look at back at the costs, they're actually pretty equal costs each. So I'm not sure that it leads us to targeting the younger. But I did know that the use rates for emergency room were lower for the elderly because I've done a lot of use rate analysis around the state and other places for quite some time, and the tendency of younger people to utilize the emergency room and older people that go to their doctor is just something that's an approach that people tend to use. Older people have, because they have more chronic conditions, tend to have a relationship more with the doctor than some younger people who might not be ill, and they just use the emergency room periodically for something. So I think that's probably the answer to why that is so. In terms of the disabled population, you'll have to think of the fact that a lot of people are disabled because they're mentally ill. So that doesn't surprise me to see mental illness in there. It doesn't surprise me that people that have HIV are having severe depression or other mental illness. And so people who are disabled are going to be more likely to have comorbidities of depression, and there are people who have a primary mental illness in that dual eligible category. So that's not completely surprising to me from my work to date.
And Debbie, did you have a part of looking at the categories? I want to, I guess Debbie Kuchka-Craig for mental health. As I listened to the presentation, I was wondering what subset of the patients would have been touched somehow versus how many are just totally were missing. And so, if I understand it, you said the last couple of slides were on the Medicare only, which is in this market largely unmanaged, I would say, because penetration of Medicare Advantage is so low. But when we looked at the dual eligible or Medicaid, I was wondering, that would be an interesting thing to see to what extent the patients that fall out here are already on other radar. And it sounds like these are largely unmanaged.
Yeah, these would be largely unmanaged, and as I understand it, the dual eligible are not in the MCOs in Maryland, so this would represent mostly the unmanaged population. The management that would be occurring would be with the transition that the hospitals are doing now with discharge planning,
right?
And potentially some other minor interventions, but not major care coordination going on for the population.
Thank you, Donna. One question on the high utilizers. This was for 2013, I believe. This was
2012.
2012. So one question that's sort of a curiosity about this is, looking back at 2011, could you have predicted from the 2011 hospital data that there would be these high utilizers based on their utilization of services in 2011? I know you didn't do that, but do you think that's more like conjecture questions? Do you think that the earlier year of data would have predicted this utilization? Going to Mark's question, which I think is really, this made 40,000 maybe a benchmark number that is the starting point. But it's not the 40,000 people that we obviously want to deal with. It may be a completely different population potentially, and therefore you're thinking about this. This is a report, but really, if you're going to get a handle on it, you have to have a model looking forward to tell you in 3 inpatient hospitalizations or more is a good metric to know, but there are probably more independent variables, if you will, that you want to know about if you're really going to get your handle on care coordination in an effective way. So I guess I'm pretty much agreeing with Mark that really this is a good start for a report, but if we want to deal with this, we have to have some models going forward that are going to tell us ahead of time who we have to intervene.
So we actually CHMH looked at 2009 and 2010, and it looked like this. So to your point, yes, I think, you know, whether it was the same 40,000, I don't know, but the same type of issues among the 40,000, yes. So
maybe just one more comment, and then we can move into the previous.
I was like sort of Steve Schenkel, potentially obnoxious request of our presenters as we move forward. But this is a question that I think anybody in care coordination is trying to wrestle with, and it's the question of prediction as a group changes over time. And perhaps we can have some of our presenters who are going to be talking about coordination comment on how they've managed that. They predict. My reading of the literature is that of the many predictive models that have been forwarded, none of them really hold up very well. So what they have in their systems to deal with this exact question.
I just have a very quick question. Patty Brown, Hopkins Medicine. Can you tell me the source of the 3,500 annual intervention contribution? Those are from some different articles and studies that I've looked at in terms of intervention costs. So it could be $200 to $300 a month, or some of the statistics that some people use higher interventions and some people use lower interventions, and there's a lot of factors that could affect that. But and so you could use a different assumption.
Okay. Thank you, Donna. I'm Jack Meyer. I'm going to be facilitating today. And I just finished, in addition to my research and consulting work, about 8 years teaching at the University of Maryland, and I was known as a kind of an easy grader. However, the one thing, and one of my students is here today, he could verify this. The only thing I was kind of tough on was time limits when the students presented their paper. So I want to apologize in advance to our wonderful presenter. I will kind of prompt you as you're getting close to your limit. I don't mean to be rude, but we have so many people with so many good ideas that I want to make sure everyone gets a chance. So the ground rules are, with one exception, that up to 15 to 20 minutes, but it's sort of hard stop for each presenter at 20 minutes. And as I say, I'll flip you a note if you're getting close. With the exception of Carol and Freya, who are doing a joint presentation, and so I agreed that they could do 25 minutes. In a way, it's unfair. I know, it's kind of unfair, but they agreed to it. But anyhow, so apologies in advance. Our first speaker is Dr. Farzana Safi. Dr. Safi goes by Fozzie, if you can know Fozzie. And she is Associate Medical Director at Mid-Atlantic Permanente Medical Group. Fozzie is the Associate Medical Director, in fact, for hospital operations, peri-operative services, utilization and case management, and network contracting. That's a lot. She has been with Mid-Atlantic Permanente Group since 2006. And she's working hard on promoting best practices across service areas and bridging gaps between inpatient and outpatient services. You're just talking about that, and internal and external resources. She got her medical degree from George Washington University, then went out west, did an internship at the Naval Medical Center in San Diego, where she did her residency, and then came back here, did some interesting work as a staff physician for the National Naval Medical Center in Bethesda before joining the Permanente Group. So, Fozzie, the floor is yours.
I think that's the whole 20 minutes.
I'm not counting that against you. You have 20 minutes.
Thank you. And thank you all for giving us the opportunity to share some of our experiences and representing Mid-Atlantic Permanente Group. I'm excited and thrilled to be part of this work group. Many of you know the journey that we have been on, and you've been part of that journey with us over the past 5 years, where we, in the 2008-2009 period, we formed a partnership with and a collaboration with our partners out in Northern California, the Permanente Medical Group. And from there, Dr. Bernadette Loftus joined us,
and really brought to the Mid-Atlantic states a lot of her best practices, the work that they had done in Northern California and Kaiser Permanente. This is just a little bit of the landscape that we cover, our footprint in Mid-Atlantic states, all the way up from Towson to Annapolis, west to Frederick, Ashburn, and then all the way south through Fredericksburg. One of the big areas that we've concentrated on is really focusing on a strong core that surrounds all of our members, and that really starts with the partnership between our members and their primary care physicians and their specialists. And that really is within the medical centers, working with the entire healthcare team. So every member has a primary care physician. If they have a specialist, they have the same specialist with whom they follow up, case managers, clinical pharmacists, the nurses and the clinical assistants, all really working around our members. And the advantage of that is we develop and create care plans that include advanced directives. They include narcotics contracts with some of our high utilizers. And really that is the basis and the way we communicate with other people that may contact our members. And so that information is available in our electronic medical records. And so if one of our members ends up in our urgent cares or our observation units, all of the physicians in those units have access to those care plans and those narcotics contracts. And everyone is working off of the same information, and that's critical, especially for these chronically ill patients. From our medical centers and our urgent care and observation units, we have our core hospitals, where we have Mid-Atlantic Permanente Medical Group physicians who are hospitalists who work at those hospitals, who have access to the medical records, the care plans, the narcotics contracts, the advanced directives, and really can make sure that we are continuing the management that started in an ambulatory setting, continue that in the inpatient setting, and then, very, very importantly, transition that and continue that work into the outpatient setting. We have other planned hospitals that we have great relationships with, but because we don't have our own physicians in those hospitals, there are times where we don't get those care plans front and center right away. And there are missed opportunities where we can have, and we look at our ER high utilizers, we look at our hospital high utilizers, and often there's overlap between those two groups. We actually refresh our list every quarter and really work on the top 150 utilizers and look at the span of their utilization. And it's really interesting to me because not only are these high utilizers of emergency rooms and high utilizers of inpatient acute care facilities, they're also high utilizers of PCP and specialists and behavioral health. And so they're really clogging up the system, and we need to look at what benefit are we providing for them? Is it the right thing for them to constantly be going out and about, or can we work on bringing care to them where they need it? One of the big things is we really have these interconnections between our healthcare team, our inpatient team, and the collaboration between case managers who really help bridge those gaps. We do recognize that we have a gap in what's happening outside of our ambulatory setting and the inpatient setting. A lot of times we don't know what's happening in the privacy of people's homes. Are they taking their medications? Are they safe? Can they afford food? So it's lovely that we have a care plan. It's fantastic that we have advanced directives, but if they can't buy food, if they can't pay their bills, if it's freezing cold in their homes, it doesn't matter what great service we provide for them. And so we have 3 pilots that we're working on. And These are not new. I don't think this is a secret sauce. They're not unique to us, but there are steps to trying to bridge the gap of what's happening in the facilities and what's happening in people's homes. One program that we're working on is what we call healthcare ambassadors. They're called community navigators, many different ways of approaching this, where we have non-clinical people go out to our members' homes. And really they're there just as if they were a really caring family member. You know, are you safe? Are you okay? Do you understand your medications? Can I help you look at what list of medications we think you should be on, and look in your cabinet and throw out all the medications that you shouldn't be on? Can we give you resources to pay for, you know, help you with the electricity? Can we give you financial assistance to help you pay for your medications? A lot of those things. So that's one pilot that we're working on. Another pilot that we're working on is we have started exploring a model that actually was developed in our Northwest Kaiser Permanente region, where they're working directly with a community EMS group where the paramedics actually work out of the call center at Northwest Kaiser Permanente. And when a call comes in and it's not something that can be easily dealt with in that call center, they actually will deploy their paramedics. And those paramedics work under the auspices of the physicians. And there's communication between the paramedics and the physicians, so they can sometimes even administer medication, give them that treatment, do an evaluation. And we're exploring this with a local county EMS in the state of Maryland. Very early exploration of this. And we've heard stories where the EMS crews will show up to people's homes, and they know the names of the dogs, and they know which door to go in because they go to those houses so many times. And yet they know that sometimes for that paper cut, they don't need to put that patient in their rig and take them to the hospital, but they have no other recourse. And so I spoke with Jean a little bit about this, and maybe we as physicians through MedChi and as an organization can change the regulations around what our local EMS can do in order to have some communication and guidance from a physician, but instead of taking that paper cut to the locust ER, the closest ER, they can actually take them to a medical center, to a primary care physician's office, to an urgent care. And I think that would be very helpful. And I know I'm going to run out of time. So. The third, and I love these stories. I mean, this is what I do every day. The third thing that we're working on, and again, this is not the secret sauce. This is not something unique to us. But we recognize that there are a group of people, specifically congestive heart failure patients, who we know every Monday morning will show up to their local ER with fluid overload and issues because of the chips and salsa that they had on Sunday while watching football. We all know them. We started reaching out to them, and we actually made them appointments with their primary care physicians on Monday morning, knowing that they would have those issues. But we're working with another organization that just has home monitoring for congestive heart failure patients, where they do daily check-ins with blood pressure, weight, and if there is a change in the weight or the blood pressure or the pulse ox, then a nurse goes out and actually gives LASIK or does an evaluation with collaboration with that member's cardiologist. Again, this is not secret sauce. This is not something unique to us, but those are the types of things where outside of this ambulatory setting, inpatient setting, we need to figure out how to get into people's homes to really find out what's going on with them. This model, everyone has seen, everyone has, which is the typical case management model. But what we recognize is our case managers need tools. They cannot cure world hunger on their own. And so we really need to have that integration between primary care, specialty care, very importantly behavioral health. So when we looked at those ER high utilizers, and when we looked at those frequent admissions and readmissions to the hospitals, many of them have anxiety and depression. I don't know which came first, and it doesn't really matter. But unless we address those, we're never going to be able to help them. So what does this all do? Many of us have had this conversation before. We cannot take all of the credit on the decreased utilization in the hospitals. So I think the world of medicine has changed, and more can be done safely and efficiently in an outpatient setting. So some of this decline in utilization is just the trend that we in the medical community have seen. But some of this also is our focused, intentional work with our high utilizers, people with chronic diseases, really getting our hands around caring for them and having them use ambulatory resources earlier and more frequently than go to the hospital, as well as their emergency room. It's not good enough just to have a plan and see that plan decrease in your utilization. You have to make sure you're maintaining quality standards. You have to make sure your members and your employees are satisfied and really gain the value of the things that we're doing. And looking at care coordination through CAP, one of the questions that's asked is of people who get these surveys, how often does your personal doctor seem informed and up to date about the care that you got from other providers and other doctors? And not that we're competitive at all, but it was awesome after our joint collaboration with Northern California that we were #1 among all of the Kaiser Permanente programs. Quality. So one of the biggest things for us is that any touch points will address preventive issues and quality issues. So if someone ends up in our urgent care, if someone ends up in the hospital, not only do we care for the issue that they present with, but we also look at their care gap. Do they need a mammogram? Do they need a pap smear? Do they need fit testing or colonoscopy? And we really make sure that that is part of our DNA, where every touch point we're looking at that, and that has really shown results. But at the end of the day, this is someone's mom or sister or daughter, and it's every single patient that we touch that matters. The same thing with controlling high blood pressure, the same thing with controlling cholesterol. We may never know how many lives we saved by diligently, intentionally, at every touch point focusing on blood pressure and cholesterol. But it really does make a difference, and hopefully it will change the demographics. More quality measures and really being recognized for the work that we do. If I have maybe 3 or 4 more minutes, this is one slide that I specifically wanted to concentrate on, because one of the questions that was asked is, what have we done, and what are some of the barriers and opportunities that I grapple with every day with my team at Kaiser Permanente and the Atlantic Permanente group. And it's great, again, for us to have those care plans and those advanced directives and those narcotics contracts. But the thing I can't figure out how to do is get that narcotics contract in the hands of every emergency room physician in the state of Maryland. Because we track our ER high utilizers, and we see patterns where we have the same patient go to 3 or 4 ERs in the same day with different stories. They've been in an MVA, their head hurts or their abdomen hurts, and they walk away with narcotics after narcotics. And so if there's a way that we in this state, when we do have a care plan, when we do have a narcotics contract, when we do have an advanced directive, break through all the barriers between the hospitals and the health plans and really get that information out to the frontline physicians who are caring for these patients, I think that is invaluable. And I think speaking with a lot of emergency room physicians, they would love that information. They would love to have that narcotics contract. So when that patient shows up for the 5th time that week, they can say, didn't we already talk about this? Don't you have a contract with your doctor? And I think that's invaluable. We spoke a lot about behavioral health, how this truly impacts everything that we do. And if we separate behavioral health from all of the other things that we provide, we will never succeed in this field. And then again, we talked about the social needs, how to get out into people's homes, how to figure out how to help them truly take care of themselves, because we can do a phenomenal job in the four walls of our building, but once they step out, anything can happen.
Thank you. That was a great kickoff to the discussion. Just so everybody knows on the work group, we're going to go through the presentations one by one. I know some of you will have some questions. Please hold them. After we finish the last presenter, we've asked 3 members of the work group to kind of tee things up and respond to a few, ask a few questions, respond to a few questions, and then throw it up into the whole work group to discuss all the you've heard and add your own perspective. And then when there's time, we will, of course, allow people from the audience to jump in. So I now want to introduce Heather Kirby. Heather is the Assistant Vice President of Integrated Care Delivery at the Frederick Regional Health System in Frederick, Maryland. I keep hearing about Frederick, Maryland. It comes up in your hospital from several different sources. So we're glad to have you. In this role, she's responsible for all the activities and programs related to care coordination across the full continuum of care and care management, discharge planning, social work, and utilization management. And she's been implementing an innovative care transitions program at the hospital as the patients transition back to the community and forming collaborative relationships and partnerships with stakeholders. So we're very glad to have Heather Kirby, and now the floor is yours.
Great, thank you. So just very briefly, I stuck a slide in my presentation just to familiarize anyone who isn't familiar with Frederick Memorial Hospital. We are the only hospital in our county. We have about 70,000 emergency room visits per year, about 18,000 admissions. We do have a new physician-provider organization, and we're recently approved for our Medicare Shared Savings, ACO, which will go into effect in January of this year, which is very exciting for us. We have all the other routine ambulatory services. We have immediate care locations. We do still own our own home health care agency as well as our own hospice, which also has a residential program. We have numerous other outpatient ambulatory settings. And we have a large group of community providers who do still affiliate with the hospital in some way. So just to give you a little bit of background about our journey in care management, we obviously have had care coordination, care management in the hospital in some fashion for many, many years. I started my career at Frederick Memorial as a social worker on a med-surg unit and have seen care management evolve in many different ways over those years. But in 2010, we were introduced to the whole idea of the change in dynamics, particularly around Project Red and Project Boost and Eric Coleman's care transitions model. So at that point, in July of 2010, we invited a large group of providers from our community, from nursing homes to outside home care agencies to the Department of Aging, our public health department, to come and talk a little bit about these models and what's changing in healthcare and the fact that we really want to move into avoiding patients returning to the hospital and how can we partner. So this multidisciplinary team wanted to look at some data, so we started looking at our patients by diagnoses, by physician type, by discharge location, by payer type, to really understand who is using hospital services and who is coming back to use hospital services. So in May of 2011, we launched a heart failure pilot. We took some of what we thought to be the best practices from the nationally recognized programs, did a pilot for about 6 months, and saw a 25% reduction in our heart failure readmissions for the control group who participated in that pilot. We did then enter into an ARR agreement, which obviously changed the way that we looked at care management. And then we launched a full care transitions program in August of 2012. So I'm going to tell you a little bit about that. To give you an idea, we kind of have 2 teams in our care management world, one of which is the care coordination team. And these are hospital-based folks. It includes a medical director, nurses, social workers, and some support staff. Really the focus of the care coordination team is what happens in the hospital. They plan for the day, they plan for the stay, And what's new to them is they don't just plan for the day of discharge. They have to be very thoughtful about planning for the days after discharge and why that's so relevant now. We do complete a comprehensive screen of every patient who's placed in a bed in our hospital, and that's regardless of patient status. So an observation patient is screened for risk for readmission or need for care coordination, just as an inpatient is. Additionally, probably about a year ago, we implemented behavioral interviewing as part of our screening process. So it was not just a look at a screen, look at a chart, ask a few questions. It really was a thoughtful behavioral interviewing process to understand what is important to our patients and what is going to perhaps present a risk for their returning to the hospital. The care coordination team is also responsible for the typical utilization management, care coordination, length of stay, avoidable utilization. But what was really different, we also implemented a care transitions program, and this was a team of folks that included nurses, social workers. We also included pharmacists on our team, and we have the support of a nurse practitioner. And this team is dedicated completely to looking at patient engagement, their health literacy, focus on medication management, access to care, community support after discharge, and patient-centered goals of care. And this team really focuses on not so much what happens in the hospital, but what happens after the hospital. So while they may be first introduced to the patient while they're in the bed, their role is really to continue to engage that patient and their care team, whatever that location may be after discharge from the hospital. The team, interestingly, they will do home visits. They'll go to SNF facilities if needed. A couple of our staff will participate in multidisciplinary rounds at the SNF, particularly for heart failure or COPD patients. And we just recently started accompanying some of our highest risk patients to provider appointments. So they will attend physician appointments with them or other provider appointments. A little bit of just briefly about the process. Pre-hospital, we are meeting with some of our community providers, specifically folks from the Department of Aging and or the Way Station. The Way Station is a mental health provider in our community. We meet with them on a monthly basis to identify shared patients who are high utilizers of hospital services. And we work with them to develop care plans for our high utilizers. So it's the hospital team, it's the community team sitting down to really identify what's driving individuals back to the hospital to become high utilizers. So we do proactively work with to develop those care plans. Additionally, in the emergency room, our staff, if a patient returns to the emergency room, will complete a readmission interview to really understand what was it that brought that patient back to the hospital. And in the emergency room, we will start the preliminary discharge planning process. So we'll start to think about if this patient's going to be admitted, what are going to be their care coordination needs during their hospital stay and after. It's not uncommon to have a patient present to the emergency room, be seen by a social worker there, and an automatic tag goes to our care transitions team that says, hey, this patient is going to return to the community most likely, and they're going to need you to be involved in some capacity. So this team can start to engage that individual and think about how they're going to manage them after discharge. Day one of hospitalization, the care coordinator is, as I mentioned, they screen all patients. We just recently implemented the modified LACE tool. We had used something that was kind of a combination of a variety of different tools, but now we're using the LACE tool. It's embedded into MetaTask, and we've added some capabilities to do some scoring and help us to identify patients who are at risk for returning to the hospital. Ongoing throughout the hospitalization, every day someone from the care coordination team is expected to touch base with the patient and or whomever is going to be involved in their care after discharge. We also develop a personal health record with the patient, so that's something tangible that they have in their hands so that they can take information around their goals of care, their advanced directives, their MOLS, their medication list. They can physically take this with them when they leave the hospital and take it to subsequent appointments. Additionally, prior to discharge, our goal is to ensure that every patient has a planned visit with a provider in the community. That could be with a PCP they're already established with, or we will help them to get established with a doctor. Part of our screening process, we do ask the patient, do you have a PCP? And what we found is we actually need to take that one step further and ask them, great, you have them. When was the last time you went to visit them? Because if they haven't been to visit them in a year or two, they may no longer have a PCP, and they may need to be reestablished. So that's an important part of that conversation. We did also, because we do have some challenges securing PCPs in a community, Mission of Mercy is very active in our community, so we engage them that if we identify a patient who needs follow-up care, follow-up primary care, they will allow us to schedule appointments with them. We can secure 16 appointments a month with them where we can actually schedule a patient for a follow-up visit after discharge, which is very different than their routine, how they accept new patients. Additionally, we do use our immediate care as well at times to provide follow-up care. If we have an individual who needs follow-up care and we can't get with a PCP and they may not be appropriate for Mission of Mercy or have a more acute need, like they need to be seen the very next day, we'll schedule that appointment with immediate care. The care transitions team is also responsible to conduct a series of follow-up phone calls. They do 1 to 4 phone calls, sometimes more, sometimes a few less. They do home visits as well. We are also, the care transitions team, the goal is for any appropriate patient to get them engaged with home health care. However, as we all know, there's a whole group of patients who may not qualify for home care. So our care transition nurses are now doing telemonitoring on a certain population of patients. If we have a heart failure patient who doesn't qualify for home care but would benefit from telemonitoring, the care transitions nurse sets them up and does the monitoring herself. The conversation that we are having is at the 30-day point. Does the care transitions team discontinue service, or do we keep folks on service and continue working with them? Just to give you a quick snapshot, when we started our work on readmissions, we were at about 10.8% readmissions. Our latest, we're down to about 8.5%. Now that's intra-hospital readmissions only. It's not inter-hospital. But the large percent of our readmissions do come back to our own hospital just by very nature of where we are. I will say, from the start, we've dropped readmissions by about 20%, but I think what's becoming increasingly challenging is we've removed a lot of the low-hanging fruit. The easy stuff has kind of been taken off the table, so the patients who are coming back are extremely complicated from a medical and a social perspective. And just to give you a sense of our inter-hospital readmission trends, we are seeing some nice improvement in our readmission trends from the inter-hospital as well. This was just a sample. I feel like a story sometimes is the best way to articulate what's very different. Mr. G, and I'm sure you have dozens of Mr. Gs as well, but he is a 60-year-old man. He has heart failure, COPD, end-stage renal disease, on dialysis, a complicated medication regimen. When we met Mr. G, he was on 19 different medications. He's homeless, he's unemployed, he's uninsured, he has poor health literacy, and he's unable to receive dialysis because he had greater than $55,000 in outstanding bills to the dialysis center. So as you can see, a million different reasons why he was coming back to our emergency room on a regular basis. During a 6-month period of time, he had 17 ED and hospitalizations and greater than $125,000 in charges. So the care transitions team started to work with him, and it took a little time to establish a relationship, but we ultimately were able to establish a relationship, invited him to come back to the hospital where he met with the team. We invited him to come at lunch. We said, we'll feed you lunch if you come meet with us. So he did that 3 times a week for several weeks. He's now on limited medications. We've negotiated with the dialysis center. He's back getting dialysis. He's still living in and out of homelessness. But his situation has changed dramatically. We've kind of helped him meet some of his basic human needs and remove some of the barriers. And in a 6-month period of time, he's only been in our ED for 2 visits. So why I share this story is pre-care transitions and pre-focus on how we're doing care management, Mr. G would have just continued to come back to the hospital time and time again, and we really wouldn't have done anything different with him. I mentioned this already. We do a readmission assessment on every patient who returns to the hospital. We want to understand why they're coming back. And as was previously mentioned, a lot of what we're finding, the returns are related to social determinants of health. It's not necessarily a medical condition. It's being able to meet their basic needs. the ongoing identification of priorities. We do have monthly meetings. We meet with multidisciplinary and multi-agency facilities. We look at our hospital EMR data. We're using CRISP data. We do conduct readmission RCAs to really understand what's driving folks back to the hospital. We've created some task force groups to look at some of those specific areas, and we will be partnering with our clinically integrated network come January to help provide care management as well. Collaboration with some of our skilled facilities. We have sat down with our skilled facilities and shared protocols, specifically heart failure and COPD. So if a patient has heart failure at the hospital, what they get educated on in the SNF and what they get in home care is consistent across all 3 levels of care. We are working on a dashboard and preferred provider agreements with our skilled facilities. Additionally, our care transition pharmacists do have access to several of our SNF EMRs to conduct med reconciliation across levels of care, so that's been extremely helpful. These are a couple of other of our community partners who we've worked very closely with in as far as providing care coordination and handoffs and transfer of care. I'm not going to go into each of them because I think we've run out of time. Just very quickly, I've mentioned a good bit of this, but we are focused heavily on our Medicare patients as well as our community physicians who are no longer attending at the hospital but have high rates of patients coming to the hospital. So these are patients coming, getting admitted and readmitted by our hospitalists, partnering with them to determine how we can provide care management to help keep patients from coming to the hospital. We did recently implement a community-based social worker to focus on our mental health population. And probably the next biggest thing that we are doing is kicking off a program around the Conversation Project and launching an initiative on National Healthcare Decisions Day, which is April 16th, which really we hope will help to educate the community about the importance of advanced directives and MOLST and advanced care planning, which is certainly a challenge that we have within our organization. And I am going to end there.
Good. Well, thank you. Thank you. And since you were a couple minutes early, thank you. I just wondered if you wanted to comment on Steve's question that he asked, if you wanted to repeat that.
Certainly. The question is how you handle the problem that the list changes regularly and the high utilizer. This period of time may not be the same for the next period of time.
Yeah.
So predictive modeling.
Well, and we are struggling with that as well. When we initially identified our high utilizers, and we defined high utilizers by 2 or more ED visits and greater than $50,000 in charges, our initial population was 419 patients. We looked at that population 12 months later, and it had dropped to 222. And so we're finding that it's not the same population, and it's constantly changing, and we really are challenged ourselves in figuring out how do you identify them and how do you, we don't have a good predictive modeling tool at this point to do that either.
Okay, thank you.
Thank you. Can I have a follow-up question? So when I look at, you presented a list of target populations, which struck me as very much keeping that concept in line. Particularly, I saw the bottom one was a really interesting one, which is children with frequent ED.
Yes.
Which struck you, and you had an emphasis throughout on social determinants of health. It struck me that that's where that was coming from.
Yeah, yeah, and it is. And actually, that's a new area of focus for us.
Okay, thanks. Again, just me being the tough professor, I didn't fill in a break. However, the restrooms are close by, the Diet Cokes and Sprites are close by. When you need to take a break, take one. Thank you. Now, I'm going to introduce the team of Carol and Atreya briefly. Carol Marsiglia is Senior Vice President for Strategic Initiatives and Partnerships at the Coordinating Center. The Coordinating Center is a community-based coordination agency. She's a nurse with a graduate degree in healthcare informatics. She's certified in case management, and she has been also overseeing a Maryland-based CCTP program transition, and is facilitating communication with hospitals and health systems transitions from hospitals to nursing facilities and all kinds of other points. I'm going to introduce both of you at once, and you can follow your own order. Freya Brown is Director of Outcomes Management and Social Work at Bon Secours Baltimore Health System. Ms. Brown has been in this role for over 3 years and has been with the system since 2008. Her area includes utilization review, discharge planning, and care transitions, all very relevant to what we're talking about here today. She created and implemented a care transition team to reduce readmissions and providing supportive care beyond the walls of the hospitals. Again, another common theme we're hearing today. She has over 15 years of experience in case management, care coordination, and community outreach. So, Carol and Freya, you're on.
Okay, thank you, Jack. Actually, I'll start off just to kind of give you an idea of what we were asked to touch on today in 15 minutes. Initiatives, no, you get 20. Oh, I get 20. Okay, so initiatives startup, obstacles overcome, technical, political, major features of delivery system reform, results today, policy implications, chemistry of cooperation, initial and ongoing challenges. So I tried to capture all that. I apologize for some of the crowded slides. But again, what I think my point is that we're really only scratching the surface in terms of how, at least from a community-based organization, is working with the new challenges in Maryland. But at any rate, I'm from the Coordinating Center, and we are a nonprofit organization. We've been around for 32 years. Our headquarters is in Anne Arundel County, and we serve people. We serve probably about over 10,000 people across the state of Maryland in some sort of care coordination program or readmission reduction program. Today, I'm going to really focusing more on the readmission reduction aspect of the work at the Coordinating Center, but our history has been doing care transitions since our inception. We initially started with children who are ventilator dependent, living in PICUs, and coordinating services to get them home, keeping them home. We also work with Department of Health and Mental Hygiene on some of their Medicaid waivers, specifically those that support long-term services and support. So transitioning people, younger adults who have been living in nursing facilities for many years back to the community, we coordinate those services. So when this environment changed to really work with discharges from hospitals, that seemed kind of straightforward, so we thought. But we're finding, there are certainly lots of challenges that we need to be addressed, and a lot of learning that we've had and that we continue to get. So I just wanted to put that into context. So I'm going to talk about a readmission reduction programs at the Coordinating Center. And we currently have kind of three programs going. One of them that I'm going to focus on today is the West Baltimore Readmission Reduction Collaborative, and that is a CCCP program which is funded through the Affordable Care Act. And I'll talk to you about that in a minute. Another program that we're doing is we have a contract with a regional suburban hospital, and that came after our CCTP program. So that particular hospital has gotten the benefit of all the things that we learned that we weren't doing so well and how we overcame them, in addition to having more flexibility built into it. The CCTP programs are really a demonstration model project, so there are restrictions within the program that is beyond our for CMS's interest. But when working with the hospitals, we have a lot more flexibility so that we're able to do beyond a 30-day intervention, just as Heather said, where there are some people at the end of the 30 days, if you could just address this other barrier, you may be able to make more progress and further reduce readmissions. CMS is really focused on reducing the 30-day return where, so we don't feel completely successful if somebody comes back day 35 and then day 90. That doesn't really, we want to look broader than that. And with our hospital
contracts we can do that. We also have contracts with some Medicaid managed care companies to work with people who are highly utilizing hospital services. And so for those, we are providing more of a care coordination model for those individuals. So I want to talk a little bit more about our West Baltimore program. And we have quite the challenge with this program. In terms of our CCTP program, there are 100 sites across the country. Our program in West Baltimore, we had the highest baseline readmission rate of any site across the country, and that average, that weighted average, was 30.4. And the other thing that put us as an outlier and climbing uphill is that our what they call our HCC score, which was a risk type score, is 2.3. And I believe the average across the sites is about 1.6 or so. So we have quite the challenge to deal with the program. So basically, for the West Baltimore Readmission Reduction Collaborative, we're working with 3 hospitals. And we're working with the University of Maryland, the main campus, the Midtown campus, and with Bon Secours Hospital. And as part of that, each of the, in terms of our relation, I'm going to address a little bit the relationship building, because again, we're an outsider. We are not a health system. We are not affiliated specifically with a hospital. So we were really looked at as an outsider when we started, and there was some skepticism from the hospital, which we were, we thought we were out in the community for 30 years. Why don't they know about us? Our coordinators are in and out of their hospitals all the time, working with the frontline staff, not the leadership level. So we had to gain some trust and credibility within the organization. So each of the hospitals had to do a root cause analysis, which they did, and to identify those that were at were some of their highest risks, and this was for the targeting purposes. So, and why were people coming back? Where were there gaps in care? The purpose of that was then to, from the CMS, we were to identify, the community organizations identify what intervention would bridge and match the gaps that they serve. So we continue to learn. We are fortunate in this particular program because the CMS pulled together a learning collaborative, national learning collaborative. So we have learned so many little things, and I will tell you, there's no silver bullet in it. There's no magic wand. It's little things, tweaking that you do that makes the difference, and you really need to do a rapid cycle improvement when you're doing this work in the community. And what works with one hospital is not necessarily going to work at the next hospital. They're very different populations, and we are currently experiencing that. So how do we do it? Okay. Again, we talked about root cause analysis. We are, our model that we have implemented in the hospitals is we have a staff, a liaison in each of the 3 hospitals. They are responsible for identifying individuals who would be at high risk for readmission. And again, we had this relationship and the work already, groundwork established with the hospital, so they're all on board with this. But basically, they have helped, each of the hospitals helped us by identifying, in CCTP, it's Medicare fee-for-service recipients that are our target population and those that are at high risk for readmission. So the hospitals each have helped us by putting together a report that daily that our liaison looks at to see who's in the hospital that's getting Medicare A and B. They also include the conditions on that report, maybe from the current hospitalization, from previous. There's a bit of a challenge with that because someone comes to the hospital not necessarily for COPD. They may come for trouble breathing. Well, there's a lot of things that may create trouble breathing. Our target is or one of the target populations for this program is COPD. So we had to figure out, okay, what are all these symptoms that we have to look at that could potentially define or pull somebody into our target group. So, so that's one of the things we do. We also do, we started out targeting
from a conditions basis, because that's how the root cause analysis is done. They looked at what people were coming at, what the diagnoses were. And certainly we ended up with pretty much the same list you'll see nationally. We'll see it at the state: COPD, pneumonia, sepsis, AMI, end-stage renal disease. We have also included mental health diagnosis in our target because that is a challenge for the 3 hospitals that we work with. And I'm finding not only those 3 hospitals, but probably most hospitals across the state. But I do think that to the degree that we have to deal with it, it's much more relevant or prevalent. So we are doing a 30-day hybrid of the Coleman intervention. CMS does want an evidence-based intervention. So again, there's some constraints around the implementation of this particular model. We do the pre- and post-discharge visits, and I have in red up there within 3 days. That's a huge challenge in this particular population when you have people who go out the door and, oh, their cell phone that they gave you, they're out of minutes, or, oh, that was somebody, that was a neighbor, that wasn't theirs. So that was a big challenge for us. And I'm happy to say, actually, we've made significant progress in making those 3-day visits happen with some learning from the CCC program, and I'll tell you how we did that. 3 follow-up phone calls over the 30 days, really focusing on personal motivators, because if we don't engage somebody within the first few minutes we're in the hospital room, they're not going to be interested in talking to us. So we don't always go in and talk about their health. We may talk about what's important to them. If it's important to them to get out of the hospital to go to a family member's wedding or their granddaughter's recital, that's what we focus on. And as we work with individuals after their home, we continue to circle around to that goal of theirs, that motivator. Let's see. Our coaches, we use a team of coaches. They are not licensed. They are health educators. Some of them have certification in coaching. Some of them have human service backgrounds, but they are not licensed social workers or nurses for this particular program. We do have a nurse on the team. We have about 9 coaches. We have the 3 liaisons in the hospital, and we have a scheduler as well, and then we have a nurse on the team. We implemented this week some new software, mobile technology for the coaches to they do a quick survey for each of those encounters, whether it's on the visit or on the phone call, and it's about 15 questions, very much in a layperson's language. The questions are based on whatever the active issue is that's identified. So if it's pneumonia, you're going to ask some questions about their breathing, maybe their appetite, their ability to sleep. Did they sleep better? Are they having problems? Did they have problems sleeping last night or the night before? So we're just implementing this technology. We have a soft launch right now. We're going to do a full launch in January. But when the coach is out there asking those questions, if the system will trigger a mild, moderate, or high alert. And basically, that it's looking at their risk for readmission. So somebody that's got a very high alert, high risk, they may go back to the hospital they may be at risk to go back to the hospital they're saying in about 12 hours. So what this allows us to do is communicate directly. As soon as that coach is in there asking the questions, the alert goes off, it goes right to the smartphone. The nurse goes right into it, links to the information, and then can call that coach back immediately. And the good thing about that is the coach is right there in the home. The nurse can have the coach put the person on the phone, so if there's some breathing concerns or, you can talk to them, and the nurse can kind of understand what's going on, ask some further questions to determine, does this warrant a call back to the physician? Does the person have the medications? Are they missing a medication? Has home health been out and engaged yet? That is something that happens. Home health referrals are made, and then maybe home health can't get out there for 5 days. So you have that gap of time, and sometimes that's the critical point when somebody would go back to the emergency room. So we facilitate that engagement with home health as well. And so when we have a high alert, we're going to urge home health to get out there sooner, and this is why, because the nurse has some of that information at her fingertips. So again, that's brand new, and several of the other sites in CCC are using it with demonstrated success. So we'll let you know how that goes maybe the next time around. Okay, measuring results. Okay, so again, we use a combination of technology. We have a care management information system at the coordinating center that's used for many of our contracts there. But we also, that's where we capture our client information, and that goes to billing and allows us to do reporting for our data, So on encounters, on coaches, which coach did the intervention. We are using CRISP, and we have been very dedicated to using it since August 1st when we started with this. Data is a challenge. CMS data is 6 months lag time. So it's very hard to make quick changes in your program when you're already 6 months out. And the other thing with CMS data is that the data that we are measured on for all Medicare fee-for-service within that are going to the 3 hospitals. So if somebody that we don't touch isn't readmitted, that counts against us. So it's very difficult to figure out then what we're doing, who we're touching, and what difference are we making in that population. So the CRISP data, I will tell you, is essential to us as a community organization to be able to make any kind of to find any kind of learnings, because we need to know who's getting readmitted, and pretty clearly. We do have some challenges with the CRISP data. Since August 1st, like I said, we have been capturing that on we get the notifications. We have learned that there's some lag time in upload of the CRISP data. So for the purposes we're using it for, so we have people coming out every day. So if we upload a panel today into the system and it doesn't get uploaded till Monday by CRISP, then if somebody comes out tonight and goes back Sunday, I'm not going to capture that on my CRISP notifications. It's going to be too late. They're already in. So that's a challenge for us. And and again, I do have a question in my head in terms of, and I don't mean this in a bad way, but just in a real way, that we have to be. I'd like to believe that that I have all the notifications that someone's admitted, but I feel like we're missing some people that were readmitted. So I think they're okay. Results today was good about. Okay, so results using CRISP. What we looked at since August 1st, we looked from August 1st to October 31st, and we served about 912 people we did an intervention for. Across the 3 hospitals, we had an average of 12% readmitted. So we had 107 captured by CRISP. And I just want to put a disclaimer in there. Again, I can't verify the integrity of the CRISP data, but that's what we're seeing using CRISP. The other thing that is allowing us to do, and now that I can match the readmission with the client, we can then start digging deeper, which is what our strategy is right now. We started looking at coaches. We had a range. One coach at Baltimore Hospital had 0 readmissions for 3 months of the people that we touched. It's been unbelievable for us. We did go back and try to validate as many of those individuals as we can, and it did seem close to pretty valid. We couldn't find anybody that was admitted. Some did go back to the ER and to observation, but did not actually get readmitted. We also had coaches that were in the 16% range, where our average was about 8. So we're thinking somewhere around 8 is probably more the norm. We have moved on some of those coaches that are 16% at this point into other roles or other places. Coaches have different skill levels, and coaching is not it's not easy, and it's different than care coordination approach. So it's really important to have those individual skills. We also have found, again, and this is month for one out of the 3 hospitals had 0 admissions during that quarter. We also had but also at that hospital, that coach had a 58% rate of visits in the first 3 days, which is higher than our average across the 3 hospitals. That was the point I made in red, doing the visit in 3 days. We learned one thing that made a big difference, and that was getting a scheduler to do those visits and having someone who is continually calling and calling and calling to get through to that person to schedule that visit. We were much more effective. We raised our 3-day visit rate from 10% to 60 to 70%. It averages by changing that one intervention. It certainly helped with efficiency as well. So again, there are little pearls of wisdom in there that you have to find within your program. Challenges, embedding staff in hospitals. Hospitals have varying orientation and badging requirements that community organizations may not have those same requirements or have differing requirements. I talked to one community organization, not for us. It wasn't an issue for us because we do have all these HIPAA policies, but a community organization who's not a covered entity, who can, like a time bank, who can support care transitions in a way, would not have those policies in place. So it makes some of the community organizations hard to partner with hospitals when you don't try to look and think and act like a health setting. So that was one thing that's challenging. Not, again, so much for us. Hiring, training, setup costs. You need the staff in place to be effective to work with hospitals when they want to contract and they want to move the needle on a population. For some organizations, community-based organizations, they may not have the revenue to fund that kind of money because there is a significant cost to that. And then you're waiting on referrals from the hospital, and if you don't get them, the finance man is not very happy with us. So that's a challenge. Inefficient processes again, and that's the rapid cycle improvements that we do. Achieving a large enough footprint to move the needle. Again, just working with a very small subset of people is not going to move the needle. You got to kind of go at it at multiple angles, and you may need multiple programs to do that. No one size fits all. Behavioral health, supportive housing is challenging. Homelessness, certainly they're the highest cost users. We talked about data systems. Choosing technology. Everybody is developing technology to the readmission, reduction, and care transition. So that's which one is really a challenge. And then continuing that relationship with your hospitals is essential, and with the community organization. And adopting, in some situations, particularly around those that are chronically homeless, a collective impact approach, because the issues are bigger than the hospital, bigger than the community organization. That's really a cross sector, and you need to get new and different partners that we haven't been used to working with. So,
Thank you.
Thank you.
Freya.
Okay, Freya Brown, good afternoon. So how do these two presentations go together?
I was asked to talk about kind of what we learned as an organization from working with Carol and her team. So the missing link for us was the fact that we didn't have people going into the homes to make sure that what they were telling us in the hospital matched what was going on in the community. So that was what we took away from the relationship, to make us realize that, you know what, care coordination should be a top priority at this point. So right now we have several initiatives within the organization in addition to the Get Well team. So we have collaborated with a few outside agencies to kind of help us tackle this readmission issue. Just to give you a little quick background, we're licensed for 88 beds. We are located in West Baltimore, and in that area the average life expectancy is about 62. Over half of our patients struggle with substance abuse and behavioral health diagnoses. So we have a lot of challenges in our area. So within our organization, we decided to partner with outside organizations in order to tackle some of this because we cannot do that alone. We have peer recovery coaches in the ED that talk to patients that come in positive for substances, alcohol, or drugs, to try to get them into treatment. We were named a health enterprise zone, and we have that distinction to work with patients with cardiovascular disease. And we've implemented cooking classes, fitness classes, and we've collaborated with 16 organizations in the area to try to tackle that. In our Outcomes Management and Social Work Department, again, we focus on discharge planning and care transition. And then we have a slew of behavioral health programs and services that we're trying to coordinate with in order to make this whole thing work. So we also establish relationships with internal and external care providers, in addition to what I mentioned before, the coordinating center, our homeless outreach program, home health companies who are not cookie cutter. We need for them to go out within 24 hours as opposed to 3 days. And we're partnering with those agencies that are able to meet those needs. And then, of course, our skilled nursing facilities and the city's area agency on aging. We've also collaborated with ambulatory centers or clinics. We have 2 on site. We have a Good Health Accountable Care organization within Bon Secours, and those patients are flagged in our ethics system. And when we see them, we contact the clinic and say, listen, they're here. Would you like to come over and speak with them, because we have a hard time finding them once they leave the hospital. We also provide follow-up care for uninsured patients at that clinic, or for patients whose PCPs are not available within that catch, those days that are required for, to prevent a readmission. So within those 7 to 10 days, if their physician is not able to see them, we will do like a courtesy visit for those patients. And then we've also educated unaffiliated clinics in the area, such as Absolute Care, Total Health Care. We've spoken to them, and we've tried to collaborate on patients that we share that come back and forth to the hospital. University of Maryland Midtown, the director at that hospital, Leslie Stremmel, and I, we met through the coordinating center collaboration, and we have joined forces, and we met with both care transition teams so that we can communicate with one another about those patients that are going from our hospital to theirs, because we have a very high readmission rate and we have a very high inter-hospital readmission rate, and we're trying to tackle that by reaching out to those facilities or hospitals where those patients are going. So as I mentioned, we're doing a lot of information sharing between the 2 groups. The ongoing challenges are trying to figure out how to assist patients with behavioral health and substance abuse issues. That is our biggest challenge. Right now, we're just taking one patient at a time. We're putting the peer recovery coaches in place. We're putting the care transitions team members in place, and we're just talking to them and encouraging them, and that's all that we can pretty much do right now until they are ready to change those behaviors. Once we identify what the social determinants of health are, the barriers are, what are we going to do about it? So if someone can't pay their electric bill and they need that electricity for equipment, what are we going to do to fix it? So that's an ongoing challenge because we can only do so much. And then length of stay reduction is another issue. Do you keep them an extra day to make sure they're okay before instead of sending them the day before, then they come right back? So it's to keep or not to keep. What are we doing, and how can we manage that successfully? And then doing more with less. We have had to make adjustments to staffing. So do we need to cross-train the nurses that are being called out to go visit some patients at home? And trying to figure out some creative ways to make, I guess, both worlds jobs. Other identified areas of opportunity, of course, would be continuous physician education, staff education, community education, and then more importantly, we have to educate the families and the patients on why this is so important, because we're coming at them with ideas and what we think they should do, but how can we communicate that this will actually benefit them in the long run? We have to be very diligent about educating the patients that we serve. Again, focusing on unnecessary utilization and appropriateness of admissions, making sure that when they're coming back to the ED and they're coming back as observation, do they really need to be here? And can we really try to focus on outpatient care if it's appropriate? And then improving the handoff and communication internally is also important because we have all of these groups, but we need to be talking and communicating and collaborating with one another. So in order to do that, the desired future state will be to integrate the electronic medical record to include those key services that need to be in the loop of what's going on with the patients that we share. We have to continue to develop non-traditional pathways. So as an example, we have one patient that came in. He comes to our dialysis center 3 times a week. He comes to our hospital outside of that, but in between that, he's going to another hospital. So we have to go to the hospital and communicate with that team professional and the patient to let them know that we're talking, and this is what we need to do for you, and would you come along with us? So that's one of the ways that we've tried to do some non-traditional things. Visit the other hospitals to ensure that our patients get like a warm hug from all of us. We also looking at trying to reestablish our care coordination structure. But as I mentioned before, we have several moving parts. And how can we bring all of that under one umbrella to coordinate the care much better? Because you have one group here, you have one group here. But how can we work together and have that one umbrella where everything falls there, where we can streamline the services that we need to provide to all of our patients? And that's it.
Thank you.
Thank you.
That's great. Frequently when I go to a wedding, either the best man or the maid of honor leads off the toast by saying, people came from all over, but the person that came the furthest was Paris or something like that. We don't have anybody from Paris today, but clearly the person who came the furthest to be with us today is Julianne Howell. And Julianne, who goes by Julie, is a senior health policy advisor in the County of San Diego Health and Human Services Agency. She's going to tell us a lot about what they're doing, but I kind of think of Julie as a sort of resident of both San Diego and D.C. She has a lot of frequent flyer miles.
Absolutely.
But just something to highlight is that she was an RWJ fellow, and since a colleague of mine, Marion Loon, and I helped start that about 30 years ago. It's always good to meet another RWJ fellow, re-meet another RWJ fellow. And her placement, they all get placed in the senator or congressman's office, was with a fellow named Senator John Kerry. And she helped him on the Senate Finance Committee and Small Business Committee, and then she worked at CMS for a number of years. So she's a Washington/Californian, and we're very glad to have Julie here and waiting patiently. So now you're going to tell us about San Diego.
I am. Where do I just get it? Okay. All right, perfect. I feel I'm delighted to be in this last position because some of the things I'm going to talk about build on everything else that you have heard. And I think we have some things happening in San Diego that could be relevant to Maryland as a state as you think about how to approach all of these issues. I actually learned about care coordination and long-term services and supports and all that kind of stuff, first on John Kerry's staff and then working at CMS. And I was on Kerry's staff when we did the Medicare Modernization Act, and we tried to bring the benefits of disease management, fee-for-service Medicare. I actually worked at CMS trying to implement Medicare health support programs. Had a lot of the learnings from that. I'm going to talk in particular about our CCTP program. And I want to tell you from the beginning, that is not care coordination, but it's a piece of it. And in California, we always push the envelope, so we brought some of the pieces together that I can help. And let me kind of walk through this, and then we can talk about more in the discussion. So a quick overview of San Diego County. It is the 5th largest county in the country by population, 3.1 million people. We are the size of Connecticut. We have 18 tribal nations, 42 school districts. We are a majority-minority population, and to put it mildly, the region is diverse. Geographically, we span from the ocean to the mountains to the desert, from Mexico to Camp Pendleton, which is the barrier that's preventing Orange County and Los Angeles from kind of infiltrating. And San Diego has always prided itself on doing things a little different. To give you a little bit of a feeling for our county government, because the focal point of what we are doing resides with our area agency on aging, something called Aging and Independent Services, which is part of county government. And that makes a difference in terms of what we've been able to do. So the counties in California are kind of the effector arm of the state, as I like to say. There are 58 of us, so we really implement the Medi-Cal policies. We do the eligibility. We have child welfare. We have the whole spectrum. The Health and Human Services Agency, of which I am a part, is an integrated agency that came together in the late 90s thanks to welfare reform, led by Bob Ross. Some of you may know of him. He is now the president of the California Endowment. That was his reward for having accomplished all of this stuff in San Diego. We have a long tradition of public-private partnerships. Our board of supervisors was all Republicans until 2 years ago when we elected the first Democrat in 2 years. So don't despair that you're getting a Republican governor necessarily. And because I was on John Kerry's staff, so you can appreciate my saying this. The fact that there was the stress on public-private partnerships and doing things together means, for example, we don't have a county hospital. What county hospital there was first leased to and then sold to the University of California, San Diego, to be the hospital when the School of Medicine started in the late 60s. So we don't have to worry right now of staying competitive with the other hospitals in the community. We can collaborate. And we have a long tradition of being a convener for the community, which has really helped in the creation and success of the San Diego Care Transition Partnership, which I'm going to tell you about really quickly. So San Diego is a long-standing, highly managed community. The hospitals and medical groups came together as integrated systems going all the way back to the 80s. So the major players in town are the SHARP system, the Scripps system. The university is finally catching up after many years of effort. I was the director of planning for the health sciences at UCSD before I went to DC. So I know the hospital environment really well. Palomar Health is a regional system. It's actually a district hospital. And at the heart of all of this, I forgot to mention SHARP, shouldn't have because they are the other major player along with Scripps, but our area agency on aging and independent services, which is part of the Health and Human Services Agency, is the community-based organization that is the foundation for this CCTP program. So we are one of the 100. We are the largest. As the largest, we have pushed the envelope. CMS really dreads calls from us because we're always asking, could we do it this way? Because we think it makes some sense.
I've been on a lot of those calls.
Uh-oh.
Not you.
Not us. Okay. We like to say that in San Diego we have co-opetition, so that the systems compete fiercely with each other, but they also come together when it makes some sense to do that. And my sense is that that's probably true of Maryland, broadly speaking. UCSD does not have the distinguished history that Hopkins does. but we are a significant player academically, and UCSD participates in this as much as Sharp and Scripps and Palomar do. We saw the opportunity to design a patient-centered system of care that would go across the continuum. We share data and best practices to realize the triple aim. And we really want to demonstrate to the rest of the country that it is possible to scale up a comprehensive care transition program, to test new approaches and interventions, to improve the health of the community, and to innovate with both clinical and social service partners. So this is the structure of the system. And I think probably each of the CCT programs is unique in many ways. But what we have done is, we think, build on the strengths of the social science, the social service side, and the clinical side, and take advantage of both, and not try to force every system into the same model, but still remain consistent to the extent that we need to for the CMS purposes within this overall structure. So AIS is the heart of the program. It does all of the administration. It also provides the social service component to everyone, and it does the Coleman model CTI coaching for 2 of the systems. But Sharp and Scripps are big enough and self-contained enough that the notion that somebody would come in and do the clinical intervention in their hospital was just, anathema. So we said, fine, you don't need to. You guys do the nursing and the clinical piece. AIS will do the social service piece, and that has worked beautifully. So AIS is the anchor. We have a steering committee that includes 3 voting members of each of the systems. We've got the CFO, the Chief Medical Officer, and a COO type person. And that group meets monthly, and at least has for the last 2 years. It will go to quarterly meetings because most of the issues have been worked out. The work team is a monthly group that brings in people from each of the systems, the lead clinical person from each hospital system. It is really a working team. We share data, we share experiences. We are very much part of the learning system that CMS has put together. But within our own community, we have a learning collaborative. There are then groups of the coaches that meet together to share experiences, and our pharmacists also meet. So basically what we are doing is taking advantage across the whole community of working through these very complex nitty-gritty details. There's no question about the fact that the government, that the devil is in the details. This is just a picture of AIS, and you've got it, and we don't need to spend any more time on it. So let me quickly run through kind of the key components of the model, because there are similarities and differences, and the appreciation that you can do it differently and still get to the same place, particularly if you're sharing the learning, I think is one of the important things that San Diego demonstrates.
Can I ask a clarifying question? So you said Sharp and Scripps do their own clinical, and the other relies on you?
Yes. So UCSD and Palomar asked AIS to do the clinical intervention, the CTI people, and so we have nurses who do that. We're kind of concluding that in truth that's not the strength of AIS, but that has been the request. So, thank you. So the available interventions, and not every patient gets everything. This is all dependent upon patient need. The issue of how do you target, who are the people that you get, is clearly one of the most complex ones. We have yet to find an algorithm that best identifies. It really is the clinical experience of the folks who are seeing each Medicare fee-for-service patient. Again, because this is a CMS demonstration, we are right now restricted to dealing with the fee-for-service Medicare population, which is still significant. among all of these hospitals, we have 92% of the fee-for-service Medicare population in all of San Diego County. So this is about as close to a population-based approach as you're going to get. So each patient has inpatient nursing support. That role is called something different in each system, but it's basically the same thing. Pharmacy is a key intervention. It was started in 2 of the systems, and the other systems quickly introduced it because so many of the issues around readmission are about medication management. The CTI Coleman model coach is an important part and was the focal point when we started, but there are many patients for whom it isn't the essence of what needs to be done. Heads nodding over there. And a piece that's unique to San Diego, at least in terms of how we characterize it, is something we call the care enhancement piece. That is the piece that AIS does provide for each of the systems. It is the social work piece. It is the appreciation of the patient who has complexity at home that's going to need somebody visiting with a social work perspective as well as the clinical perspective that the nurse brings. So it's somebody who's appreciated. That patient has no food waiting for them when they get discharged. And because we are at AIS, the Area Agency on Aging, we have the ability to get the food there. We can arrange Meals on Wheels. We can have somebody come and do a tuck-in service for a week to be sure that everything's okay. So those little things that are not clinical, but that make all the difference, are part of what is offered. Not to everybody. It's expensive to do that, but to the people who need it. And one of the great things that's happened because of this collaboration is there's learning on all sides. So the nursing staff within each of the hospitals, and we have 13 sites that we're dealing with, have come to appreciate what to look for with a patient to identify where you're going to want the care enhancement intervention there. So a couple of the sites have their own unique things. Sharp has introduced something that they are calling PAN, post-acute navigation, which is basically the Eric Coleman model, but done on the phone. That's being moved to one of the other hospitals as well. Now, it took some persuasion with CMS, but they finally let us do it. There are many patients who don't want somebody coming into their home. And this is a way of providing that same support and coaching and self-actualizing, if you will, but through a telephonic route. And it's proving very successful. And UCSC does some follow-ups by phone for people who are not getting the CTI. I won't walk you through this whole game board, but it basically shows you how a patient goes from admission to the hospital to the various decision points along the way of which intervention the patient will get. You can remember, some patients will get everything. Some patients will only get selected ones. But the ultimate result is, we hope, preventing a readmission and a healthy patient. Everyone who gets readmitted has a root cause analysis done of that readmission to find out what went wrong. We created our own information system. Each of these hospital systems have their own electronic health record, but they're different. We don't have something quite as comprehensive as CRISP yet. We do have the San Diego Health Exchange, but it's still in the process of getting launched, and there isn't a database yet that can be called upon. So Alex, and I asked, why Alex? That is apparently some Greek hero who is the protector of man. That was the source of the name. So information about every patient who's enrolled in CCCP goes into Alex. We capture the basic patient identifying information and clinical information, and that is also, and the interventions that are done, that is then the source of information that is sent to CMS for invoicing. But that information is shared with all of the participating hospitals, because each patient can get an intervention only once every 6 months. And there is, even with these systems, people show up in different systems when they get readmitted. So you have to check to be sure that the patient hasn't already had this intervention. So that is all shared. Alex is the source of ongoing management information that is also shared. So at our monthly work team meetings, we get this analysis of what has happened across the program and in that month. This is the summary statistics. Each hospital gets its own, and that is also shared with everybody else. So we have the basis for tracking how we're doing overall. At this point, we see about 1,400 CCT patients a month. As of the end of October, we had done 23,000, which is by far the largest volume in the whole of the CCT program. I talked a bit about care enhancement. This gives you a picture of the patients who need that intervention. It's not surprising when you look at it, you can see it, but a significant fraction of these people are dual eligible. They are low income. They are exactly the population that you expect will need that additional social support. And the fact that AIS is a community-based organization that has the long-term services and support at its disposal is a key piece of our ability to be successful. There are other programs going on in California in which AIS is also involved, like a dual eligible demo with Melanie Bella's shop in CMS that begin to interact with what's going on with CCTP, but that hopefully will also provide the long-term care coordination that we want. But this gives you a feeling for the population that's served by this enhanced program. All right, what have been our results? If you look at the readmission rate, our baseline compared to where we are now, it has gone down somewhat, but through work that Dr. Joanne Lynn has assisted us with, we have found that it's not just the readmissions that are going down, it's also the admissions that are going down. And so that rate is not a very good measure of the success that we're having. Instead, if we look at exactly the people that we have been treating, our baseline for this target group was almost a 40% readmission rate. For people who participated in CCTP, there's about a 14% readmission rate. And for people who actually completed the whole intervention, it's about a 12% readmission rate. So clearly very successful for that piece of the care coordination that you can address through a care transition. So trends and outcomes. The Medicare population in San Diego is growing, and we are. But even with that growth, the hospital admissions are decreasing, as I mentioned. So, because we have such a large fraction of the fee-for-service Medicare population under management, if you will, it's really legitimate to say, well, what happened to the population readmission rate? Not just when we look at that readmissions divided by admissions. If you look at 2010, 11 bennies per thousand per quarter readmitted. 2013, down to 9. So successful when you look at it at the population level. And calculating what we have contributed to Medicare, which is, of course, a key piece of Medicare's perspective, we estimate that we have saved 437 admissions, readmissions, and net of program costs, Medicare has saved about $2.6 million through this program. So we are being extended for a third year, and are delighted about that. All right. What are some of the key lessons that we have learned? Certainly how to work together. I was not in San Diego during the early stages of this effort, and I understand it was really quite interesting for that important. But by the time I joined at the very end, as we were negotiating with CMS for our actual agreement, the degree of collaboration was already extensive. And it is just, I sit with the work team every month, and it's impressive to see the camaraderie, the collaboration. I think one of there are two quotes that I've got to give you. One is from Scripps, which was the system that was least interested in participating at the beginning and is now one of our greatest champions. And then we had a visit from the Lewin group that has been working and supporting this whole effort. And the kind of lead of that site visit, as we were doing a debrief at the end of it, she said, you know, the San Diego Care Transition Partnership really has accomplished our vision of what CCTP would be. And so that was obviously something that we were thrilled about. So it is possible to do this in a very competitive environment. It's possible to bring the clinical pieces and the social service piece together and to have real information sharing and understanding through that process. We are indeed educating the next round of health professionals. There is a program that Cal State San Marcos and UCSD are pioneering that will be providing nurses with advanced practice training in care transitions and geriatrics, and also a certificate program for people at the bachelor's level and the master's level. So it's really providing a basis for enhancing the whole community.
Thank you. Well, from camaraderie among rivals.
Yeah, absolutely.
We can all learn from that. Here's what we're going to do. We are going to have, we've asked 3 of the work group members to respond. We asked them to talk about the key elements that they've heard and how this could be spread in Maryland, how it could be made to work here, what areas it's going. Of course, they can innovate flexibly. So we're going to do that first, and those are Patty Brown, Alan Tapp, and Debbie Craig. And then when they're done, I've received a bit of feedback that a 3-minute stretch break
would be appreciated. Yeah.
But it really will be a stand up and sit down because I want the whole work group to have a chance to comment. But so we'll do that after the 3 lead-off comments from our work group members, and then we'll all collaborate and react to what we've heard. So, Patty, if I could ask you to lead off.
Thank you. So I'm Patty Brown, Senior Vice President for Population Health at Hopkins Medicine. And what this has been really fascinating and very helpful for me as I'm thinking through the challenges that the committee chairs have defined for us. So I wanted to ask each of you all, actually, from your own vantage point, the question as to if you were in the seats of the chairs here, if you already have decided that you have the right secret sauce, the right arm. The real question is how would you scale it? Like, we're trying to figure out how we can create some opportunity that we can scale quickly to support the state's goals and each of our goals. But before I ask you each to say that, answer that, let me just make sure that we have this right. This is what I've heard. What I heard from each of you is that you need to figure out a way to identify and target high-cost conditions. That there's a targeting effort, so you can't do everything, and you've got to figure out who are the right people. But each of you seem to you start from a different point. So Kaiser, by virtue of who you are, you start from, I'll put words in your mouth, so it's kind of an ambulatory starting point. You have clinics, you have patients, you have physicians, primary care specialists, you have an EMR, and you can start there. Our hospital colleagues seem to be starting from what they have, which is hospital information and people that are at the hospital. And then the experience that I've heard you reference seems to be that you're able to do kind of both. That you have access to information that both from a community perspective as well as from the delivery system. But that's a key component, right? So
is there, I'm asking rhetorically now, is there a way to scale that? How do you go about identifying and targeting high-risk individuals? The next, and that goes to the predictive modeling question, I think. And I think that would be a question the state is asking. Is there a way to do that in some type of facility, some type of way? The other thing I think I heard each of you say is that there's some type of care plan. There's some type of document, some type of effort to connect that patient's needs to a planning process, a care plan. And that care plan then has to be shared. It has to be shared across some type of team, be it your team that's more hospital-based, be it more broader-based. And then how does that happen? What's the exchange? How do you do that? And then each of you talked about interventions, which many of them were evolved or developed from evidence, right? I've heard Coleman, I've heard Booth. So there's best practices, and is there how do we refine best practices? How do you always know what the next best practice is? And then how do you set forth those protocols in a workflow that can be scalable, that can be so that seems to be part of everything that you said. The other thing that each of you can do references and how do you make the patient experience. So it's not just about what we do, it's about how you get the patient. And that's then perhaps some of the new protocols around home-based services and the connecting out, going beyond the provider of care to something else. And then finally, measures. And what are the metrics? You know, they seem to be similar in that we're defining readmissions, but really, is that all we're doing? Is that really all that we're trying to do is prevent readmissions? And then we have to connect those metrics to the cost. So if those are kind of the categories of work, you know, although you're each doing them differently, I think that the question I would ask is just if there was one area that you all, that any of you in your particular work would say, this is the area that we really need to work on to be able to scale any of that. If you really want to focus on how you take your program and implement it at a broader level, you know, what's that first priority? What's that one thing? That was really what I thought I'd ask.
Thank you.
I mean, very much as you characterized, I think the Kaiser program is very much community-oriented with a longitudinal care model, very much in the overall picture of how Kaiser looks at the Frederick is a hospital-based model with wonderful tactics also, targeted at care coordination, care management. The care coordinating group is a community-based group. Again, there's wonderful tactics that we have at how to address the issues of current readmissions. And the San Diego is a coalition of hospitals, maybe others, at least a coalition of hospitals. Kind of at the core of it, somewhat proprietary, but generally distributed information systems. And I think the question about all of this in terms of scalability, I'm not going to answer the question to answer this. I don't know if you all get a chance to answer the question. I was looking for what the secret sauce is. I think that the real answer really has to do with, I suffer from week after week. So for the last 4 years at least, weekly I get together with care management. It started out to be just the care managers from the state MMTP program, the demonstration function. 3 sitting around the table. Expanded to care managers, including care managers who care first. So 7 or 8 sitting around the table. Expanded to one hospital, another hospital, a third, and a fourth hospital. And then to community-based care managers who are affiliated with hospitals. And then the ACO care managers from 3 different ACOs. So now there's 58 people sitting around the table. Quite a big table. Most of it's telephonic. But it's like the Tower of Babel. It is. It's just like the Tower of Babel. Everybody with wonderful tactics. Really very good tactics. All looking at the same thing. How to improve the health of the community. But still, the issue at the basis of the basis, what I think we all struggle with, is the lack of interoperability. And if I had to characterize what I think the scalability issue that will prevent us from scaling anything, and I would appreciate all of your input on this also, is lack of scale, is lack of interoperability. And it's not our, I think it's throughout our industry. If I can take one was a gentleman, Malcolm McLean, who I met years ago, a little business company. He started out as a truck driver, got into a big trucking company, and it was all about taking things from one place to another. National company. He became very frustrated because when his trucks went to the shipyard to ship things, he had to wait for the stevedores to unload the trucks. The trucks took days, sometimes weeks to unload. They were loaded the whole boats. Boats sometimes took a while to unload. When they got to the ports, loaded on other trucks, and to get someplace else. So it was a tremendously expensive, inefficient system where you couldn't go from A to B with simply transportation of items without a lot of other missteps along the way. He said, why don't we put boxes on the backs of the trucks and take those boxes off and put them on ships and then take them off the ships. And we started the Sea Land Company. He changed transportation. He made it the cost of transportation go from somewhere around $3 a ton to somewhere around 8 cents per thing. And it was all about just simply interoperability. It was taking, knowing what the business he was in, which was transportation. It wasn't about, everybody has a job, unloading, loading, shipping, captain of the ship. We all have jobs. We're hospitals, we're doctors, we're health agencies, we're community agencies. But our business is still about healthcare. And I think that's really just kind of at the core of it, how we can get interoperability in healthcare so that we can do all this together on the same platform, the same language. And I think in Maryland, we have the opportunity to do something like that with the HIE. That seems to me to be the way to expand. And I'm not here to really solve problems. It just seems so obvious listening to everybody that that's the piece that's missing, how to put the continuum of care onto a platform that everyone can see, whether it's a community agency, a hospital, or me as an ambulatory provider, and focus on the patient and have all that information for the patient on that one platform, not on a lot of different things. So in terms of scalability, that's the barrier I think that needs to be overcome.
Excellent analogy. Debbie?
Probably similar kinds of comments here. We heard a lot about the partnership, the data-driven, focused effort, multidisciplinary across the continuum. And I heard over and over again, no secret sauce, nothing new, no magic bullet, but yet there is the tenacity of continuing whatever works for that individual patient and getting, as Patty said, the patient engagement involved. I think we all look to Kaiser as that wonderful, almost perfect. You say you're very modest about it, but boy, we covet the fact that you can share all that information. And to Dr. Hack's point, clearly that is something that we in Maryland need to take into account as a barrier. Even with the information that we have currently in electronic medical records, with availability of CRIS, we still have the privacy concerns and the barriers there in order to get the information real time in order to make it of good use. And I think that, wherever we are in this world, that's going to be a huge barrier. So easy to say, well, you're in a certain geography and it's, Frederick, so that may not work in Metro, Baltimore City, or easy for you at Kaiser because they're all yours. In every presentation, I saw some real important components that we could implement, without a lot of barriers. But yet, in order to do it as effectively as we need to, I think there are some big hurdles there in terms of that interoperability.
Thank you. Now what we're going to do, let me give you my definition of a stretch break. Patty's already started. Several of you going out into the hall and having a 10 to 15 minute number. All standing up and stretching. You do your exercises if you want, and chat a bit with each other. But let's really keep it to 3 to 5 minutes so that the whole group and the work group can come and discuss these. As we reconvene, I just wanted to make one little announcement, and that is our good colleague, Dr. Amy Outwell, is listening in by phone from Boston. Amy, we hope would join this meeting. She did come to the first meeting, as some of you will remember. She had a conflict that kept her from going from Boston to Maryland today, but she is now joining in front of the phone. She can hear us. She's having a little trouble getting the audio to speak to us and jump in. But I wanted you to know she's listening in. She will be coming again to visit us in one of our meetings, at least. And so, Amy, they know you're listening, and if you get to figure out a way to chime in, your thoughts are always welcome. So now the floor is open, thanks to the work group members for your patience and all the presenters for lively and interesting presentations. I took a bunch of notes. I learned an awful lot. And so the floor is open for now to work group members. We will reserve some time for the rest of you later to add your own comments, questions, experiences, anything you want to ask the presenters, or just raise additional issues that haven't been covered. This would be the time to do it. Lori.
I guess when I listened to the presentations, I heard over and over again, in every one of them, except perhaps the last one, behavioral health. Behavioral health is a challenge. Behavioral health, we don't know what to do. Behavioral health. And I'm sitting here in kind of a time warp. You know, the interoperability is one issue. For me, there's an awareness level issue, and that is that at the risk of being accused of shameful self-promotion,
I think I wouldn't do that.
People are running for the IT expert, but let's hope it was temporary. Continue, Lori.
A lot of the things that are being brought up today are things that we've been doing in the community for 30 years, and I think you made that same point, Carol. And so the whole going into people's homes, making sure they've got food, making sure that they've got transportation to docs, going to the docs with them, making sure they've got meds. All of those things are things that we've been doing. The whole new notion of community health workers. These are people we've been employing for 30 years. Not paying them very well, mind you, but employing them. And so I guess I'm wondering, how do we connect the dots between the hospital need and the existence of a whole set of programs out there that are working for people, but there doesn't seem to be any knowledge of these things out here. How do we connect those dots? So, and some, I guess, Frederick, thank you for using one of CVH's members, Wait Station. And there are others I know in Montgomery County. Family Services has been working with the Dentist Hospital and some case management and has some very good results in that initiative. So that's my question or comment to the group.
That's very good. And I would just tag along to that. In addition to the challenge of getting it known, there's also the challenge frequently of getting those types of community-based services paid for. And, you know, I mean, I'll just give you one example. I'm working with a group now called, some of you may know them, Green and Healthy Homes, and they do home visits for kids with asthma, adults too. And then they do, I mean, a complete 2-hour thing, you know, finding all these risks from pillowcases to mold to tests and everything else that you can think of, and remediation. They didn't ask me to figure out how to do it because I don't know. They asked me to figure out, among other things, how do you get Medicaid to pay for this? If they don't, you know, or lead-based paint, or all these other things. And so they get grants from foundations, which are helpful, but, you know, they have had, and other groups like that have had trouble having the payer streams because they're not a medical service, and the definitions in Medicare and Medicaid are starting to change. There's a little light came in January from CMS about what they can pay for and who can deliver it. These are not delivered by doctors and nurses. They're delivered by people that come and assess and fix up your own. So we have that medical model issue. But remind people, for those listening in, when you talk, just to give your name. Other comments? Yes.
Adrienne Ellis with the Mental Health Association. I just have a couple of comments. I echo everything Lori just said and also everything you just said, Jack. I was going to bring up the same point of, I think one of the issues, I heard everybody mention community health workers or some version of community health workers in their program that they're running. And I wondered if we might not be kind of double managing people's care, right? So that some people might be getting case management from the hospital, they might also be getting it from their mental health provider. And so if we are, in the interest of interoperability, finding a way to have a revenue stream to pay for some of that case management, it may help save dollars so that we're not, so that CBH provider isn't paying for it with a grant and then the hospital isn't paying for similar case management out of their budget. So I think finding a financial stream for it, whether it be Medicaid or some of the uncompensated care dollars coming back or something, would be a way to make sure that savings are found and it's not being duplicated. And then I think Patty also kind of going down this road a bit when she, it looked like a lot of the metrics or a lot of the measurements the programs we're using were, and I'm sure this has a lot to do with your PMS demonstration programs and they kind of tell you what you have to measure, I get that. We're readmission rates, and while that's great, as the consumer representative, I feel like I would be remiss if I didn't mention that I feel like we should have a measurement that's about improved health outcomes. To gentlemen's earlier points about trying to get people before they have their chronic illness is not managed well and they're a high utilizer. If we can improve people's health outcomes, maybe we can keep them out of the hospital for longer than just 30 days.
Point well taken.
Yes, Mark Elliman. So Julie, a couple of comments of questions. It's a very impressive program, huge scale. But what we're talking about here is double the number of people and geographically probably twice as long, twice as far, probably 8 hours from one side of the state to the other. So do you think anything would have done differently if you had more scale to deal with in terms of putting the program together?
What I'm struggling with is I think, based on some conversations we had during this stretch, I'd start from a different place. And I think Kaiser has the huge advantage that it has a population for which it is completely responsible. And I think what you've got to figure out for the rest of the population is how do you mimic that in some way? How do you identify who the people are? I'm going to use another San Diego example because it's very relevant here. We're an integrated health and human services agency. We serve close to 1 million unduplicated clients. But a lot of those people are in multiple parts of our agency, which right now have separate information systems, even though we are integrated in theory. We are in the process of creating an overlay to that, which will pull information from each of the systems so that we can actually see the individual and the family who are getting multiple services and deal with them in a person-centered way. So basically what you need to know is who are the people, what are their problems, what can I do for them, so that you're not sending 5 case managers to this high utilizer. And we've seen that happen, right? You all have. So I think you've got to back up a step and say, when I look at a population, for service Medicare, since you're not very managed right now, Medicaid, a lot of the challenges in the Bon Secours situation have got to be your Medicaid population. Hopefully, Medicaid has expanded in Maryland. In California right now, 80% of the population is on Medicaid. So you begin to have a basis for actually identifying the people and what their needs are, and then you figure out, all right, how are we going to meet that? So the care transition piece out of the hospital is one key part of that. But I think I'd answer the question from a population perspective first, because you definitely need a clinical component and you need a social service component. There's no two ways about that. And my guess is that the infrastructure in different parts of the state varies as to who should be in the lead with that and how you make that happen. But you really have to step back first and ask, who are we dealing with?
Second question in San Diego. So one of the things sort of unknown is how much better palliative care to some of these changes. So use of palliative care, do you have any data?
One of the things I should have mentioned, the SHARP system has been really a leader in advanced care planning. And it's one of the things that they've incorporated into what they do that isn't officially listed as an intervention, but it's an essential part. So, and San Diego had a fabulous San Diego hospice, which had fabulous palliative care, and that went down the drain a few years ago for all kinds of reasons that we won't go into. But San Diego as a community puts a lot of emphasis on palliative care and hospice, and I'm sure that that's a piece of what's going on.
My final question, I think I want to bring Don into this. So, really outstanding program, half the size of the state of Maryland, $2.1 million in Medicare savings annualized. What's our number that we have to save Medicare? 3 years of the waiver?
So 5 years of the waiver is $330 million.
I just want everyone to sort of...
So that's why you have to start with your Medicare population and understand it, and don't do it hospital by hospital. Do it, at least regionally within the state, because that's where you're going to have to go to make that kind of change.
One of the small modifications, Julie, you're only calculating readmissions. So if you add the admissions, you're getting up to the scale you're going to find appealing.
Okay, well, and to build on what Joanne just said,
first year of the program,
the most.
I've already been through that math, and there's actually it's only part of a year. It doesn't include. It was during the startup time, and it doesn't include all of the money. So, I definitely have being the accountant. I actually pointed out the same point that you did, and we had a little bit of an exchange on that already. So I think that the numbers actually bigger, and than that.
The most expensive part of what you do is absolutely in the hospital. So reducing hospital expenditures is key to achieving the savings you need to for Medicare, but you've got to figure out the other pieces as well.
I wonder if I could go back to Patty's question, that because we went around, she asked 3 questions to the group, and get some of you to the panel, if that is, to respond to her questions. A couple that I wrote down, but correct me if I didn't get these right, Patty, were on these care plans, how do you know what best practices are? And second, how do you engage the patient? Some of you have talked about that. And related, what measures, what metrics, this has come up just recently when one of you brought up not just readmission, I think it was Adrian. Would any of the presenters like to address that? Start with the care plan. What goes into it? What's it based on? Evidence? Any thoughts from those of you who presented?
Can I actually take that?
Yeah, please.
Because I think that the first 2 questions were, what is the right target group? And then what is the information or the documentation, and how do you support them? And I think we all mentioned the high utilizers and the overlap of the high utilizers of inpatient and emergency room services. And even with our contained population, we do not have containment or control over all the emergency rooms and hospitals that our members are going to. And so even with that, that is an area that is significantly lacking for us. And I think it is easily within the power of all of the hospitals to make a commitment that if a care plan exists, or if a narcotics contract exists, or if there are advanced directives. So if if we already have someone engaged, we don't even have to, if there's someone engaged and that already exists, how do we cooperation, you know, how do we put aside all of the competition between the hospital systems and really just share, if we already have information that exists, how do we share that? Because that is the right thing to do.
Anybody?
Can I jump in on that? And I know we have a couple of leaders from CRISP here to talk a little bit about that, because I know we've been talking, we are uniquely positioned with our health information exchange in the state of Maryland. One of the things we've been talking about are medical orders for life-sustaining treatment. Can CRISP become the platform where we're sharing potentially not only MOLS, not only, if you will, the advanced care plan, I didn't see a narcotics contract. I've never seen one. But narcotics contract, these other places, can CRISP do that for us? Or is this a place where we need to make a significant additional investment to build out that capability?
So, I mean, I think that, and David, I recognize, is back there and back, but CRISP has already started offering advanced direct information. Not yet MOLS, but there's a fledgling effort to do that. The actual patients constructing those, the uptake's been a bit slow, but I think it definitely is feasible. It's going to involve some additional cost, however. So I think that's feasible. I did also, since I have the floor momentarily, I think that a couple things that I thought were significant about the Kaiser presentation that I'd like to tease out is that I think recently Kaiser mandated that all X number of your physicians connect with CRISP or apply. I don't know if you've been able to see results in that, but the other broad question is, given that you have a closed population, the ability to direct patients to your own embedded emergency department, urgent care centers, and et cetera, is that some advantage in the success we see?
So many of our physicians do have access to CRISP.
I think everyone's been directed to do that.
Which is invaluable, because there are still pieces of information that are outside our enclosed EMR. And one of the big things is not only is it important to see a lab value in and of itself, but if those labs exist in 5 separate emergency rooms and 5 separate hospitals, we're going to miss those trends. And that's the beauty and the value of CRISP, and that augments the system that we currently have. One of the challenges is absolutely if we have the advantage of our members calling us and we can direct them to our urgent care facilities or observation units or one of our core hospitals, great. But with some of our high utilizers of emergency rooms who have narcotics addiction, they choose not to call us on purpose. And we track them, and they go to multiple ERs on the same day. Or you can track where they're driving around Maryland, Virginia, D.C., getting their narcotics. And so a narcotics contract is where there's an agreement between typically the primary care physician, an addictionologist, and the member. And there's a plan. And we recognize there's some people who have chronic pain. Recognize it 100%. But this is a plan of medication over time that you're going to get. No more, no less. If you need more, we'll work on it as the core team. And being able to provide that, so I've tried to reach out to some of the emergency room departments throughout the state, and they say, we cannot take that information from you because it's a HIPAA violation. So how do we spread that information so it's easily accessible and we get rid, make it that we're all one community within the state of Maryland?
So I put a plug in for the prescription drug monitoring
program.
Prescription drug monitoring program. And all CDFs 2 through 5 have to be reported, whether it's dispensed, given out from a pharmacist, a physician, an emergency room, all have to be reported. So my understanding is that all Kaiser their docs now have to look at the PDMP before they give, you can correct that.
No, you're right. No, you're right.
2 through 5, but in the same way that you would use CRIS to assess lab values, you can also see where patients have been, and at least what I've heard from some ER physicians is that when patients are told they're going to check CRIS, patients are walking out. Now, that doesn't address if they'll find somewhere else, but some of that is we're starting to see a decline in that because of the PDMP.
So I think those are all pieces of the puzzle, right? But I think if we can arm the ER physician who has 100 patients that they're trying to take care of, someone comes in with acute abdominal pain, well, it kind of sounds right, and how do you not do the $1 million workup over again? How do you know there's already an agreement? That's where the narcotics contracted care plan for someone with terminal cancer, they absolutely need those narcotics. But what is the plan? What are the other things that we can do for them? And how do we share that across the state?
I already wrote a note to Steve David about that.
About 5 emails about narcotics contracts. I would defer to Dr. Kellerman on the other questions about most and such.
I think one of the key decisions that needs to come forth is we have Medicare, and that's 66% of the really high utilizing hospital inpatients. And there really are no care plan. There really are no care coordination plans that exist for Medicare today because there's no managed care companies that were driving those. So the hospitals have to drive those. So the question in my mind is, should we have a standardized care plan for the patient? And so, there's 2 options. One is to have a standardized care plan. The other is to try to make everybody's care plan somehow available through CRIS. The standardized care plan approach would be like having these things that go on the back of the truck that you take off and you put on, because they're all alike, they're all the same size, and and people know exactly where to go in the care plan to get what they need or to fill it in, versus each having their own and trying to broadcast it through CRIS. And then what you have to do is the doctor has to figure out where Hopkins has their stuff on theirs and where MedStar has their stuff on theirs, and there's still a reconciliation that has to take place. Well, who's kind of in charge of this patient? So I think it's a decision point that you all need to drive at this point of whether you want to try to standardize the Medicare care plan. And Kaiser has standardized care plans that they use, and so that really helps their doctors. I'm kind of a fan of standardized care plans if folks would go for that. But that's part of the really discussion and decision that needs to be made.
Donna, I think you can actually have both. You can have a standardized care plan and have it on the back of an HIE so it's generally available to everyone. I think it's the best of both worlds. I know New York State did an experiment that was quite successful with PICSNI, the Health Information Exchange of New York, and Care Central, which was basically a multi-agency, including hospital and providers, program that had basically care plans by patients who were registered in it. They were very standardized, but pieces of electronic records, pieces of community services, pieces of the care plans from the hospital all were available on the same platform, so that it reduced duplication. And if I recall from the study, it significantly reduced, which I don't think it's necessarily the most important thing, but the high utilizers readmissions, who was the initial tranche of people who were engaged. So I think you can do both. I think you can have a standard box and have it also on a widely distributed, generally available system. With the HIPAA restraint and all those kinds.
I guess somehow one of my slides disappeared, but of the I'm not sure what happened to it, but of the high cost of the high utilizers, over half of them use more than one hospital. So, first of all, we start with, for these patients with more than 3 admissions, more than half of them use 2 hospitals or more. So you start out with 2 hospitals or more, then you add 8 physicians or more, and that, and so everybody's doing their own care plans and then trying to share them. That's really where that you get a lot of duplication and you actually don't get a lot of usability. So that's a lot of the concern about not standardizing I'll call it a care coordination plan.
So Debbie, this is I hear you and see the benefits of doing that. I guess where I keep coming back to care plans, though, I know as we've implemented our population health initiative at MedStar, it's somewhat agnostic to payer, Medicare, whatever, because we're doing a lot of things by disease. But a lot of that effort is not hospital-centric. It's in the practice.
Right.
So when you talk about the care plans in regard to hospitals, we don't do it that way. I mean, the hospital is part of it, but it really needs to be that care coordinator working very closely with the primary care doctor. And then on the risk stratification, folks, when, before they're chronic or trying to get them at their level of need, making sure that we get them into a physician practice, not the hospital. So hopefully they never encounter the hospital. Right. So this to me seems like further down the road if we're starting with high utilizers in the hospital when we talk about care plans.
So Stephen and Penn, take a slightly different direction because I'm intrigued on your comment that in high utilizers there are multiple hospitals involved. And I'm sitting here thinking, darn, people going to a bunch of different hospitals? But it's occurring to me that it's probably not that. I suspect many of these are repeat medical hospitalizations. And these are sick folks by and large. And they're calling ambulances. And in both the D.C. area and certainly in the Baltimore area, it's those ambulances that are taking them to whatever different hospital they're taking them to. And by and large, not entirely, many patients would prefer to go back where they were seen, were hospitalized the first time around. And I think I can speak for most physicians that they would like them to go back to where they were hospitalized the first time around because it certainly makes life much easier. And I don't know if that was something that, I know it's something Kaiser runs into around Baltimore. I suspect it was part of San Diego. But that's actually an interesting, slightly different way of tackling a problem of information flow.
Yeah, I guess I'm not so sure that it's all ambulance traffic. Some of it is, but when my husband was dying, he went to Hopkins for his diagnostic treatment. He went to GBMC for his radiation therapy, and when he got sick on Christmas Eve, he went to St. Joseph, not in an ambulance, and that was based on patient selection. And there's a lot of patient selection in addition to ambulance traffic. And there's a lot of traffic back and forth between the academic medical centers and the community hospitals too. And so that's really there's a lot of and there's a lot of patients that's hopping across the city hospitals for sure too. So I think that's a lot, some of the challenge that you run into, and it's not just about where the ambulance was. It's really a lot of patient-driven selection also.
One thing, I had an example this week where the system drove them back to the hospital. The person came out of the hospital had made it out for about 28 days, went in with some kind of an arm injury, but had some mental health conditions, which is how we targeted them. Came out, as the month went on, the lady got increasingly paranoid to the point where she's showing the coach nail holes in the wall, and people are talking, and people are going to come get her. She's fearful, very fearful. She won't leave the house. She's afraid to go because the people are going to get her. So the follow-up visit that she had at the geriatric mental health clinic
she wouldn't go to because she was afraid. The clinic, because evidently this has been a cycle, won't take her back because she doesn't show. So then we're trying to figure out what to do with this lady. She's walking around the house. She's taking handfuls of pills. The pills that she's got are wet inside because they jingle and somebody will hear her. And the answer we went back to through our hospital system, through the mental health clinic. We went to we made an APS referral, and because we were very concerned about her, taking these pills. And at the end of the day, what we kept hearing, call 911, call 911. That's the last thing we can do. And what was that going to do? That was going to bring her right back. So it was very frustrating. We made the 30 days, but again, we didn't, we won the battle. We didn't win the war on that one. And she's going to cycle again. I know we'll see her again.
But I do want to get back to Debbie, because I certainly agree with you that it's starting in the primary care. And I guess, again, do we want primary care doctors to have to figure out how to use 15 different care plans for Medicare patients, or do we want them, to learn how to use one?
I just wanted to, Patty I'm sort of just doing the order here, a little bit of facilitator, and I didn't forget that Patty was next. Patty, Adrian, and then Howard.
So I hope to try to facilitate kind of a framework for next steps, because what I've heard is that there's some consensus forming around how to approach the problem in a generalizable way, because that's what you're looking for. And I think we should define care plans a bit, or to be a little bit careful here, because there are all components of the healthcare delivery system creating care plans. And I think we want that to continue. And I think we also have to be careful in suggesting that there are Medicare beneficiaries running around the state of Maryland unmanaged. I just think that's not a true statement. And primary care physicians are actively managing their Medicare beneficiaries. Hospitals now, as we have heard, are actively working to try to manage their Medicare patients. So I think what you're saying, though, is that there's opportunity somewhere to scale some of that in some singular, perhaps, way that's affordable, that can give you the comfort to say, well, we're doing something towards some measure, some metric. Because otherwise, people are just doing really good things, and hopefully one day we'll look back and say, admissions went down and costs went down. So I think we're looking for what's that direction, and arguably Chris has created an opportunity for us to even have the conversation. So it seems to me that we're not going to solve the problem today, but just to categorize the areas in which we can go get some additional information, and then think through, like, what would be that right, generalizable, scalable solution. And so I'll just try to start here, because it seems to me we've got to figure out how to identify the right patient. So we believe that there are people that are creating, that if we were touching, could help accelerate the cost management goals. And so there's experts. I appreciate the commentary around predictive modeling and challenging may not actually work. Well, there are some models that seem to look better than others. And so I think we can find out what's that right way of creating a high-cost list. And that's not just the who cost a lot of money last year. And there's a lot of information. So we kind of create a little think tank quickly on that. And then what is that information that you would want to see in a document that could then be shared? That's maybe not the care plan that the primary care physician is actively working, but it would allow someone else to have information if that patient goes, so it's a different type of care plan perhaps. Because I can say we're all generating care plans, right? And then how would that information be transmitted or shared? Could Chris create some opportunity to do that? Frankly, unless we get primary care and ambulatory care providers into the data into CRISP, there's going to be a lot of limitation. And then what are then the best practices to intervene around that information, again, generally? So I appreciate your point that you've been doing things forever. And you all,
very much enjoyed your presentation about what you're doing. And we all have innovation, community health workers, neighborhood navigators. What are those new things that we want to introduce into the mix that people would say, you know, I'd like to buy that. This is your SIN grant, basically. Some of the things you have in your SIN grant. But, you know, just a couple of those categories that then you would feel better saying, Donna, oh, my Medicare patients look managed. They look like there's something else going on that gives me reason to think they're managed. And I think that we got to figure out what are those areas, because we are managing Medicare patients. Primary care physicians are managing their patients, but they're not doing so in a way that gives you the ability to pull out information to say, oh, I'm looking like I'm driving towards a metric that's going to get me the waiver. So I don't know. I just think we can identify what those categories are and then go and figure out what the experts would say. What should the predictive modeling be? What should that care plan look like? And then what are those interventions? Are they managers running around, or are they neighbor navigators? Are they regional strategies that the consortium comes together and says, for this region, that's what this intervention should be?
And I'm going to come to Adrian and Howard in a second. I just want to pick up on your point by encouraging the group to think about, we can pick this up more at the next meeting, the kind of investments that you would recommend that the state might make, never mind which agency, or where we have all of them represented here, the different key agencies, fortunately. You know, in things like, I came up again, no electricity, no food in the home. You know, it didn't come up, but lacks transportation, but it does come up, and all these things. But also lack of interoperability, which of course is a different thing. But there may, and of course scale has come up again and again. People have asked us, how do you bring these things to scale? And to some extent, I think I'd like the group to think as we go from meeting to meeting, that we'll want to come up with some recommendations. What sort of public goods could we form that all could share from that would address some of these shortfalls, that while everybody's trying to practice medicine, they keep finding that their patients have these other things in their life. Underfunded substance abuse treatment centers, if they're even around, lack of community mental health centers or not enough of them. So I encourage you to think of, and we'll try to spend more time at the next meeting, of where could we recommend investment, either that the state can make or that the private sector, the commercial sector could make, that would meet some of these cross-cutting, both, you know, physical health, mental health, and social needs.
Jackie?
Yes.
Prerogative of the chair, sorry. And may I just add to that, because the list of potential investments is long, and I think the challenge that this group is wrestling with is we're trying to figure out what are the 2 or 3 things that we can recommend with limited dollars that would be better if we did them together. It's a narrower slice of where can we invest. We could all put together a list of that. It's where, if we made that investment, could we do things better together as it relates to care management? And I think it's a smaller, much smaller subset.
That's a very good alteration to what I said.
To build on what you said and what Patty was saying as far as the care plan, but even what were the core informational pieces that would help any provider in any system. So I'm thinking of a PAM list, problem, allergy, and medication list with the medication. And so to the point that was mentioned earlier, we're managing our patients. When I used to see patients, I'd have everyone bring in their medicines because they were on antiretrovirals, but, you know, one provider gave them hydrochlorothiazide and somebody else gave them HCTZ, and the patient didn't realize that it was the same medicine, so they would be taking both. And so there was some way to centralize some of that information that leads to outcomes that drive utilization in an emergency room or admissions for the failure patient. So what are the core pieces of information that would be beneficial to everyone, regardless of whether they're the community health worker, the nurse, the psychiatrist on the team? And even if we thought about how would you present that information, something like a web-based registry that everybody has access to, but is visualized in CRISP, let's say, so you could have access to it and see the other information, but be able to access it from multiple points, whether from the practice or from the payer source or whatever, because it was a web-based platform.
Great.
Just to be conversation about something to do.
Great. Adrienne, you've been waiting patiently, and then Howard.
Right, and now you've added so many more things. For the rest of our time. No, so just to echo a couple of things from the consumer perspective, I can definitely say that yes, everyone is doing care plans, and they're all very different. And if people do go to multiple hospitals, not necessarily just because the ambulance takes them there, but for example, I work mainly with mental health consumers, obviously, and there are some hospitals that in Baltimore City there are a little bit more set up to work with our folks, and so they go to that hospital. University of Maryland has a psychiatric emergency room, Johns Hopkins, so that's where folks are going to choose to go when they get immediate psychiatric care. They may not choose to go to the other hospitals, but they may choose to go to those hospitals for maybe their medical concerns. So they are going to different hospitals, and they are getting different care plans from all of them, and sometimes they go to a different emergency room and their medications get completely changed, and they don't understand exactly what Dr. Scott was just saying. They don't understand that this medication is the same type of medication that this is. They're taking all of their medications. So I just do want to put a pitch in that we should be thinking patient choice and patient first, and one of the ways to even start that is by having some, whether it be a standard, I understand there may be some reticence to move to a standardized care plan, although there is some precedence for that in Maryland. We do have a uniform treatment plan. We do have uniform advance directives. There are some uniform forms that everyone is using. So we're not going to go down the road of having a uniform care plan once we define what that is. Having some very specific information and that isn't duplicated, or that a hospital or ER doctor who is seeing a bunch of patients can look at. They don't necessarily change the medications that somebody just got 2 weeks ago without actually making sure that someone understands what those are. Simplifying it is the easiest way to make sure that a consumer can actually, or a patient can actually participate in their health care and actually will engage, because we can send somebody to their house and tell them they should do all of these things, but if they're not invested, they're not going to do them.
Thank you. Howard.
I'm not going to go over the phone with this interoperability stuff, but I think it's really three things. Interoperability is, without having a framework for universal communication across the silos, whatever that is. And out there, I would say, let's look to best practices. If this group has to decide about where the investments made, where is the best practice from a company or a state that is able to provide that kind of cross-silo, uniform, interoperable communication, number one. Number two, standardization. Everybody can do whatever they want. In healthcare, that's going to always be the case. If you see one, you see one. But there ought to be some standard setting, as you said, of information that would be the kernel of truth that would prevent the majority of duplication as number two. And number three is follow the knowledge. Who's going to take care? I think right now that's where is the best ROI from any of these things. Primary care, or actually not just primary care specialists, whoever does care plans now, CMS, beginning in Jan 1 will have a PM payment for that. I think that's probably, possibly a game changer in terms of what the flow of dollars, if it's utilized. But it does require care plans. It would be nice to be able to have those care plans standardized if that is possible and generally available. So I think those are my three things: interoperability, standardization, and funding.
Could I jump in on that? And maybe it's asking a question of the group. I want us to be careful. We just had a conversation internally in our organization. We were talking about data. Anybody says just data again. What do you mean by data? Could we talk a little bit more about interoperability? And perhaps talk about what are the one or two things we could do to advance interoperability in Maryland. I've heard a couple of things today. We've been talking about is there some, I don't want to go to standardization yet, but is there some common content that we want to make certain that there is a shared access to. Patty, I think, with your comment around the primary care connectivity. If we can't be successful unless we've got primary care physicians, should that be our first most important immediate push? Can others sort of just add on to what I think is a really important point we're talking about here today, interoperability, and make some suggestions as to, what are the nuggets that we need to think about getting to?
Great, and I know that we have, I think, 2 leaders and Chris here today, so if they would like to join in, please. But who on the work group?
Patty and Mark are Chris leaders. So.
That's 4. Yeah, I was referring again to others, but yeah.
So I not to beat Debbie Downer here, but interoperability, right? Just because the state of Maryland says it's so, does not mean that our IT systems can move data in a standardized way, right? So just because we are almost at a place where we have a standard around advanced directives to say there's a standard for whether a patient has or has not had this advanced directive. There's an upcoming standard about what's actually in that advanced directive. There is no standard for narcotic contract. There is no standard for what we call mulch, and there is no standard for care plan. So CRIP, which is based technically on moving data by approved standards, will struggle as your solution set unless we make it more generic, right? Unless we make it more generic. And to Carmela's point of how do we get more, if CRIS is going to serve as a vehicle for the movement of information between the hospitals and the providers, doctors, nurses, care managers, care coordinators, mental health providers, if CRIS is going to serve as that facilitator, then it has to be able to get the data from some of those providers. Right? So we talked about Kaiser consumes data from CRIS, but doesn't get published data from CRIS.
Thank you. I just wanted to note, it sounds like I'm talking about NASA. We've just gotten connectivity, I believe, with Amy Boutwell. Accident spaceship is elected Boston. So Amy, if you can hear us and you would like to add a point to this discussion, please jump in now.
Oh, great. Thank you, Jack. I appreciate it. This is, I really wish I could be there, and it's a fantastic discussion. I wanted to share 2 thoughts briefly. One was with regard to the question I think Carmela posed about what 2 or 3 things. And it occurred to me, listening to the San Diego, and I'm familiar with the Frederick Memorial and the Coordinating Center experiences, that there's a very short term, and then there's a medium term step that I think we're learning about today. The shortest term one is, it seems to me that the special sauce, if you will, the unifying factor in the San Diego experience is everybody got a different nursing or clinical or coaching intervention, a different dose and intensity of pharmacist, med rec, or whatever, but they were all, if I'm understanding correctly, they were all screened and assessed for social service needs in the community that the AAA could provide. And so I might say that a proximal unifying action would be to effectively link individuals with social service agencies across the state. And then to the point about care plans, I think that's a medium term because my observation is that we've all been talking about care plans have somewhat different definitions. There's, as a hospitalist in the ED, we would want the type of care plan that one of our colleagues was talking about 20 minutes ago, about doses of medications, when to use narcotics, when to do repeat imaging. That's at the medical clinical care plan level, whereas there are other care plans which, in Donna's language, care coordination plans. Who's on the care team, what services are in place, et cetera. And developing a care plan, I think, can be done in the medium term. And what I wanted to share was that in Massachusetts, we are currently standing up high-risk care teams in 28 of the 49 hospitals across the state. So over 50% scale. And we're doing that in the next 12 weeks and going live in the next 12 weeks. So we've spent the past 2 weeks actually vetting care plan technologies. And this is where I can say that although the definition of care plan differs, there are cloud-based, potentially HIE-based, potentially standard, potentially custom functionalities out there that that vendors have put some thought into developing. And not that I'm saying that a vendor solution is necessarily the path to go down, but offering that the work of the Massachusetts Health Policy Commission in this rapid deployment of high-risk care teams, inclusive of linking to social services and developing care plans, is probably something that we can learn about together and share with you as we move the conversation forward.
Great. Thank you. Rapidly deploying care teams.
Could you embellish on your ability to identify and target individuals?
Yes. We are not going to use predictive analytics. We are going to use retrospective data analysis to understand the characteristics of target populations, and then use those characteristics plus clinical judgment. Basically, in all cases, social complexity or behavioral health comorbidity will get you qualified for linkage to services. High utilization, social complexity, and the presence of a behavioral health comorbidity. And really, if you look at any population, at that point, you're really getting into a substantive population. And then, of course, medical complexity as well. So we're eschewing looking at diagnoses. And this is coming from my work on the Pioneer ACOs. A lot of the Pioneer ACOs have walked away from actually even exclusively defining their population as high cost, but rather are you medically complex, socially complex, or frail? And that's some new thinking that is really informing the way I'm doing this in Massachusetts.
Great. Thank you, Amy. Okay. In a minute, we're going to, in a couple minutes, we're going to ask if I know there are a couple people out there that would like to make a comment. Are there any other work group members before we do that, or presenters that have a response to one another, or a point you'd like to make that you haven't had a chance to make?
One question. Don, on the information on these high utilizers, I noticed that the 5 counties that are the highest per 100,000 are Caroline, Queen Anne's, Garrett, Somerset, and they seem to be rural counties. Is there any, and if you look at the numbers, they seem to be geographically, the rural ones seem to do a little worse. Is there any reason for that, or do you have any idea, or is that one of those things when you said you need to look more to the data?
Well, I think if you look at it, you'll find that those counties have more 85-year-olds than the national average, and I have not age-adjusted the data yet. So
okay,
in order to take it to another level, I'd separate out the seniors and maybe do some age adjustments.
That makes sense, because I think Kent's in the top 5, and they have one of the highest numbers. Yeah, that's logical.
Part of it is just saying that there's a high proportion of patients around the state.
No, I was just curious if that was
that's the reason. It's the age of the older age of the population in those areas.
And the second question I had is that you have the map in here on the cost by jurisdiction, and I noticed that I'm curious, and I certainly don't know what hospitals' rates are, but is there a correlation between the hospital HSCRC rates and the cost
per patient?
Yeah.
I mean, that would look it looks like it might be, and this is based on my very rudimentary understanding. I'm sure you or Carmela know much more about that than I do, but it looks to me like there might be, based on the colors on this map, there might be a very strong correlation.
Yeah.
Interesting point.
Thank you. Now, what I'd like to do is, as I look out, I don't consider us having an audience. I think we have a whole bunch of experts out there that just don't happen to be sitting at the table. And I'm going to, Jim, where is Jim? I promised Jim the first question because he really wanted to ask a question about 2 hours ago at least, and I made him wait. And so, Jim, you get the first comment.
You want me to stay here or Mike there?
Whatever you like.
Okay, I'll
get you on mic.
Takes me back to my theatrical days. I'm Jeff Piles. I'm representing the Maryland Home Care Association as well as the American Academy of Home Care Medicine. And as I listen to this, I've studied this issue of care coordination for the high-cost chronically ill for at least 20 years. And as I listen to this discussion today, I get the impression from it that there are many ways to do this right. In fact, my experience is there are not many ways to do this right. There are lots of ways to do it wrong. And Mr. Meyer there apparently has already given you or at least cited the CBO study from 2012 that detailed 34 straight failed chronic care coordination programs that CMS has tested. And I worked with a bunch of experts. We designed a program called the Independence at Home program that's now been enacted as part of the Medicare statute. It's actually in the statute. It's in its third year of testing. And it appears it's going to be the first successful chronic care coordination program for the high cost ever tested by CMS. And the results are supposed to be out any day now. But I would urge you, one model I have not heard discussed today is the home-based primary care model. And I would urge you to at least consider that because based on my experience, that model has the most independent, verified data showing that it actually dramatically reduces costs, reduces hospitalizations, reduces nursing home stays, reduces ER use, I mean by dramatic amounts, and it does it routinely. The VA has been running a home-based primary care program for over 20 years, and they run that program now in over 300 locations in every state. They have over 70,000 people in that program. They have got a ton of data for you to look at. And they're an impartial source. They'd be very much willing to share it with you. But I'll just run through just very quickly a couple of the lessons we've learned from the Independence at Home program in our design of it and the vetting of it and now the operation of it over the last 3 years. One is you get what you pay for. If you pay for savings and good outcomes and patient satisfaction, that's what you'll get. But if you pay up front, if you pay any organization up front for just providing care, you'll get debt. You'll get a lot of cost. The CBO study says it's actually entitled Lessons Learned from 34 Failed Demos. And one of the things it learned was don't pay folks up front and have a threshold savings that you require. Minimum savings of 5% or you're gone. And that's what we designed into Independence at Home. Primary care physicians have to be, I mean, the special sauce we found over the years is you've got to get the primary care practitioner into the home so they can do the kitchen biopsy. They've got to do that. Experience, make sure that the organizations that do this had some experience. 24/7 availability so that you avoid that ambulance ride to the ER at 3 a.m. when the patient's short of breath. That's the way to reduce hospitalizations. Independent verification of savings, everybody will tell you that their program saves tons of money. Get independent verification of it. You'll see a lot of those savings will evaporate.
don't assign the patients. Let them voluntarily enroll. Not like ACOs where the patients are assigned. People are committed to their own health care if they involuntarily enroll, and the families are too. Learning collaborative, huge, hugely important. Your hospitals, I mean, this is a wonderful opportunity for you because your hospitals are all in the same boat. But what we found is if you let these organizations who are providing these services and doing it successfully, let them get together once a month, they will develop solutions, and they're going to be effective solutions. And I guess the last thing I would say is the good news for Maryland is the good news for the country. And that is that 5 to 25% of the patients account for 50 to 85% of the cost. That's great news. It's also great news that we have done a terrible job of taking care of the high-cost chronically ill, because that gives you a great opportunity for doing a better job in reducing those costs. But I urge you to at least throw that home-based primary care model into your consideration, because it's the only one, as I say, that this seems to have really hardcore bulletproof data. Thanks. Yeah, sure.
Just to the comment, so there was a study several years ago looking in education and incentives to teachers to improve scores among students, and paying them up front didn't get the scores up, and promising them the money down the road didn't get the scores up. What got the scores up was paying them the money with a threat to have they reimburse the system. That's when scores went up. And so,
well, the design in Independence at Home is you pay fee for service during the year, and then you have savings sharing at the end. But in order to get that savings sharing, you've got to get a minimum savings of 5%. And if you don't get the 5%, you're gone. So that you have a constant self-culling, and only the successful programs then participate. And also on the care coordination model, I mean, CMS has developed a care plan. They've developed that for Independence at Home. It's been tested now for 3 years, so you might want to look at that.
Okay, thank you. Rob has a question or comment. Rob Cohen.
Hi, Rob Cohen. I just had one comment related to targeting and one potential recommendation. I'd be curious about Julie's thoughts, only because you have so much experience with Medicare fee-for-service demos working with CMS and others as well. But as we talk about places to work together, it seems that one place we could work together would be to collaboratively request specifically all the Medicare data from CMS and park it in one place and use it to do predictive modeling. You can start with the Medicare system. The HCC system is a good system, and then you can overlay proprietary work on top of that. If you can get the Part D data, you can use it for predictive modeling, gap in care analysis. That then leads into the HRAs, where you further get down the road in terms of learning about social needs and behavioral health needs. But I think that when you have such a big population you're starting with 800,000 Medicare beneficiaries, and Medicare has such good data and such good longitudinal data, that's a very good place to start, to narrow yourself down. And it's a place where if we all agree to do it together, it's much more cost efficient to get the data, park it in one place, do the predictive model. That then leads into the HRAs and the care plans.
and what are the barriers? I don't know the answer. So what are the barriers to getting that data?
I think you asked that the last time, too.
Yeah, I did. So I don't know. How can we help?
First of all, the hospitals would have to agree that they wanted to get the data, or the state to get the data, the hospitals as providers to get the data and park it somewhere, and we have to file a DUA to make that happen. We have to tell CMS what we're going to do with it. So where you're going to put it, what you're going to do with it, and so we can get, if people get to a point where they agree that they want to do this, then we can start down the road of creating the checklist and getting the process rolling. So when we have the nod, we can get that process started. But until we have the nod that people actually want to collect the data in a common place, really the state is not a provider. So that is really a barrier to us moving that forward.
Can we get some clarity on that, Donna, if I may jump in, because isn't the issue I want to make certain we're all on the same page, that the data that Rob just talked about requires accessing personal health information so that we can link across episodes of care. I think we have more of a barrier, I think, but you're smarter in this than I am, more of a barrier than just do we want to. It's do we qualify to receive it? And you think that we can? I mean, that's been the barrier. Do we qualify under HIPAA to be able to access the data?
So Medicare has the data. All right. There is this thing called the CCW, Chronic Condition Warehouse. Got created with the Medicare Modernization Act. Originally, it was going to be just for people with chronic conditions, but Mark McClellan was the CMS administrator at the time and said, let's do it for all Medicare beneficiaries. So there is a longitudinal database of all Medicare beneficiaries from all sources that Medicare pays fee-for-service. Yeah. So if you don't have a lot of health plans here, that's good. You can't get the health plan data. You've got the fee-for-service data. If the agreement that you have with Medicare for this global budget is an arrangement with Medicare, then the question is, you know, what entity within the state or wherever could do the analysis on the data that would help you identify the high utilized or high risk Medicare beneficiaries in this state? Now, I don't know how to negotiate that exactly, but Medicare now has a chief data officer, Niall Brennan, who is brilliant. And the big effort is to get patient identifiable kind of put out to everybody. But in light of what you're trying to accomplish, I would think that there ought to be some way of doing joint analysis on this data.
And just to be clear, because the issue is not desire, the issue is not how do you do the analytics, the issue has been will they give it to us?
And who's not? Yeah, well, who's not?
The hospital, so the agreement, the hospitals are the ones globally budgeted. So I would maybe start by saying the hospitals are joint, there's sort of a three-way agreement between the hospitals, the state, and CMS. So it started with the hospitals who are ultimately taking the risk,
right,
jointly submitting a letter saying, we want the data, here's what we want to do with it. You park it somewhere, whether it's CRISP or elsewhere. You then buy predictive, you then bring in a vendor to run the predictive analytics. But the idea is that the hospitals are asking jointly.
If I could answer Carmel's question, the answer is yes. HIPAA does permit care coordination, and if the patients are participating voluntarily, they can always agree to allow the access.
Just for example, CareFirst has a demonstration, and they get all the data for their Medicare beneficiaries. We have a demonstration. If we have the will to do this as a statewide coordinated effort, then we should be able to ask for the data in a coordinated fashion and get it. We haven't made that decision yet as a hospital field, so we have to make that decision first before we can start crossing the barriers to making it happen. But we will have the data already starting in January. We will have the data at HSCRC. We will already have access to the data, but not to use for care coordination. And we have intentionally not asked for things like name, address, and et cetera that you all would want to get to use it for care coordination. But we will actually have the analytic data. We could start the analytics sooner, even while we're waiting for name, address, and serial number down the road to use for our demonstration, because that's the sort of thing that we're allowed to do with our demonstration already.
Well, I think I see the makings of a recommendation that might come out of this group, because I'm hearing a consensus, starting with Patty and others. Well, let's find a way to do it. It's not easy. As one who's petitioned CMS for data more than once in my life, I know how long you have to wait and what you have to go through. But I'm hearing a recommendation. Let me see if there's others. We only have a few minutes left. If there is anyone in the group back there that has not had a chance to comment that would like to, please signal me. Steve.
Have you? Yes. One of the things that I think is sort of obvious, but it's sort of subtle and it gets lost, is that we really need two things. We need stuff we can do in the pretty short run. And we need the stuff that's going to take longer, and if we don't start it now, we won't have it in the intermediate run. And I would take as an example this idea of building a database that you can get certain information out of from the Medicare billing data as something that's going to be in the intermediate run. By contrast, if you have the ability to roughly identify people tomorrow afternoon, say by looking at the number of hospitalizations and some of the reasons and so on, that can feed into an effort the day after tomorrow, kind of, because as you've heard, you've got a lot of infrastructure out there that could use this. So I'm not trying to advocate for particular things, but rather to say I think it's very important to have two buckets. One is the bucket of things we can do tomorrow, and the other is the bucket of things that take a couple of years of effort to get you where you want to be.
Okay, thank you, Steve. Now that I have only two real responsibilities as a facilitator that are important. One is to end the meeting on time, and I'm going to turn it back over to the co-chairs in a minute to wrap up. And the other is to remind you of upcoming meetings. So, but I also want to thank everybody who presented for wonderful presentations and our responders for very good questions and the whole group. I want to also thank my colleague Matt Rowan, who's sitting over there. Raise your hand, because Matt helped me in innumerable ways make this meeting happen, and so did the co-chairs. I couldn't have done it without their advice and help and everybody. But the next meeting is January 7th. Am I right, Matt? Yeah. Yeah. It's January 7th at 10 to 12, 10 a.m. to 12 noon, and it's back at HSCRC. Thank you for hosting today. And so with that, I'm going to turn it back to Carmela and Laura to wrap up.
I will offer some thoughts if I could. And while I talked about a secret sauce, I was listening across the presentations and the discussion, while there may not be a single recipe, keep with me, I think there are some common ingredients. And if I could just read through a few of those, but then bring us back to our task at hand for this group. I'm feeling a sense of frustration. I'm guessing you're feeling a sense of frustration about where we go, but some thoughts. Number one, common ingredients, bridging the gap between the healthcare system and home. That is a tremendous challenge that we face. Number two, interoperability. We heard from various folks that providers need to be working from the same information, whether that's advanced directives, shared protocols, narcotic contracts, or something else. Number three, integration. Whether that's integration in terms of embedding providers across settings, or integration in terms of not separating behavioral health or non-clinical needs from the work that we are trying to engage in. Number four, the role of primary care physicians. Number five, care plans, including advanced care plans. Number six, relationships, a personal connection with the patient you're trying to assist, the individual you're trying to assist, and connection within community. Detailed interview and screening process for all, convening to learn from one another, and a root cause analysis for all readmissions to better understand what we're after. Some of those, I think, are common themes to our challenge. And this is going to continue to be hard for us, I think, as a group. Best practices are helpful, but our task is not an assembly of best practices. Our task, and we've said this at the HSCRC Advisory Council, is focus. is to make strategic recommendations about what we can do as a state, a couple of things that can really leverage our ability to do care coordination better. And to the two buckets comment that was made, maybe there are two buckets for us. There are a bucket of things we've learned today that are helpful and important and add to our understanding of best practice on care coordination. I'd like us to come back next meeting and think about focusing on that second bucket. Where are the places we can work together to make a difference? And I think you're right, Jack. I think we've come up with a couple of examples today of where we might do that.
And I would just add, out of the common themes that we all heard today, maybe to the point, Mark, that you made about Chris' abilities or inabilities as far as standardization and flexibility, what are the things that we should consider standardizing? And they may not be standardized today, but for the purposes of shared information and then having a place where that shared information can go that everyone has access to, like maybe a care plan. And what are the things that we should be flexible on, like maybe how we define high utilizers depending on what part of the state you're in and the kind of access to data that you have. So just across those common themes, should we be also stratifying them one more? What should we standardize and what do we keep flexible?
Great. Thanks to everybody. Have a good weekend.